that musculoskeletal infection either occurring de novo or following arthroplasty, implant fixation, or after an open fracture is indeed very challenging to manage. To cover this wide and very clinically relevant area, we put together faculty from across ASEAN. All our speaker colleagues are authorities in their respective fields, and I'm confident that the deliberations of this webinar will enrich our knowledge immensely. To reach a wider audience, the webinar is being live streamed on OrthoTV. Moving on, it is my pleasure to introduce my colleague who will be moderating the webinar. Mr. Khairul Azmi Abdul Kadir has the distinction of being the first fully trained and qualified Brunei orthopedic surgeon. He finished his orthopedic training in Liverpool and leading to FRC's orth examination. He was also awarded MPhil for his basic science research in orthopedics. He is currently a specialist in the department and also head of the Department of Orthopedics at Ripas Hospital in Brunei, Darussalam. Mr. Khairul, the virtual podium is yours. While Khairul is getting his problem sorted, let me sort of take you through some housekeeping tips. We will have one lecture after each other, and because there are discrete topics, we'll have question answer session at the end of each topic. We would expect the speaker to stick to their time for about 15 minutes, allowing us 4 to 5 minutes for question answer session. I would request the audience to pose their questions on the question and answer part of the webinar strip at the bottom of the screen. We'll start off with the first lecture, which will be on septic arthritis. It is my pleasure to invite Dr. Halim Rashid, who is a consultant pediatric orthopedic surgeon from Kuala Lumpur, and he'll take us through the various aspects of septic arthritis. Over to you, Dr. Halim Rashid.
Thank you, Prof. Ketan. Let me share the screen. Okay, can everyone see the screen?
Yeah.
Okay.
Yes.
All right. Okay. Thank you again to the organizing committee, the AOA, the distinguished committee members of AOA. Thank you for inviting me. I will be talking on septic arthritis in children, right? Okay. To start with, I think when we talk about septic arthritis, it always almost being referred to as infectious type of arthritis, right? Bacteria is always the main cause, while others such as fungus or viral can be also the causative organism. Almost always, septic arthritis will be bloodborne, and usually it involves the large joints, especially the knee and the hip. I would say that actually in children, the hip are more common to be seen, and in adult, I think the knee will be more common. And in terms of demographic, it will affect mainly the young child as well as elderly. But last but not least, the patient that who are immunocompromised, such as diabetics and those with autoimmune disease. Okay, the pathophysiology, I think this picture just to show you on how the hematogenous spread coming to the joint, right? The most common way of getting septic arthritis, sometimes we get a direct inoculation from a penetrating trauma to the affected joint, and occasionally we can also get a direct spread from adjacent bone, especially in cases of metaphyseal osteomyelitis, right? This is just to show an example of a child who actually presented initially with a flexotenosynovitis, but end up also to have a septic arthritis of the hip, and this is the most common way of spreading of the infection through the blood supply. Okay, in terms of microbiology, all right, commonly I think based on the age, you can have different type of organism, but mainly you can see we are getting it from the gram-positive type of organism. For example, in the neonates, Streptococcus is more common. As a child get older or the person get older, Staphylococcus aureus start to comes in. Haemophilus influenza has been used to be common previously, but I think slowly being eradicated following the vaccination program, right? And I think the atypical organisms start to come in cases where actually patient who are IV drug abuser or patient with sickle cell anemia, and last but not least, I think nowadays people start to talk about Kingella kike as the emerging pathogen among the pediatric population. In terms of clinical presentation, I think being a septic arthritis, sepsis infection in nature, I think the presentation will always present, patient will always present with form of fever. The fever is usually of high grade temperature. Because of that, they will also present with chills and rigor. The patient appear lethargic. And one of the most important clinical signs that we can see in septic arthritis will be pseudo-paralysis of the affected joint. The joint will be very painful, especially when we attempt to move the affected joint. The joint is swollen and the skin overlying the joint is also warm in nature. Okay. When we talk about diagnosis as well as investigation in septic arthritis, I would say that actually it should be diagnosed mainly by clinical assessment. Septic arthritis must be being diagnosed through clinical assessment. If we perform joint aspiration, all right, that will be diagnostic, and by sending the aspirated fluid for culture and sensitivity, that will be confirmatory for what type of organism that we are dealing with. On top of that, we may be able to do some form of blood investigation as well, where we look for the raised white blood cell, raised in CRP, the inflammatory markers, ESR, as well as the sending the blood for culture and sensitivity. Okay, we talk about radiology. All right, I think radiograph will be the mainstay, but radiograph might not be able to tell us much, especially in the early part of the septic arthritis event. What we can see in the radiograph could be just a widening of the joint space. Ultrasound may be of helpful. MRI has been done, but I think in our setup, MRI is a bit difficult to get, as well, especially in children where you need to put the patient under general anesthesia. One form of investigation that I think nowadays people start to forget to ask is actually gram staining of the specimen, right? Okay, based on the clinical as well as the investigation that we send, I think culture criteria is one of the important criteria that we look for. Initially, culture give us 4 criteria, which mainly the temperature, the inability to bear weight, the ESR, as well as the total white blood cell count. And the prediction shows that actually if we have, and each parameter will be given a point, and if we add all together, the likelihood of the patient to have a septic arthritis is very high. And I think Kate et al. Modified it by adding CRP. It become another predictors, and this is called the modified culture criteria. But having said so, if we add all the criteria, it just help us to say that actually the likelihood of patient to have a septic arthritis is very, very high. Okay. Okay, just talk a bit on the management. I think the mainstay, not the mainstay, one of the important management in septic arthritis is the use of antibiotics. We may start the antibiotics as empirical, but once we get the culture and the sensitivity, we may change it to therapeutic. And I think most of us here have the antimicrobial guideline based on the hospital or the national needs. I think in Malaysia, I think this is the guideline at the moment for septic arthritis, right? Based on the possible organism, the cephalosporin is of choice, especially the first generation and the second generation, which is cephazolate as well as cefuroxime. The duration is always debatable, but I think nowadays is almost agreeable that for septic arthritis, the total duration of antibiotic prescription will be about 3 to 4 weeks in total, right? In terms of administration of antibiotics, the intravenous antibiotic will be given until the patient start to improve. Mainly they become afebrile, the inflammatory markers start to normalize, and then we can change it to oral antibiotics to be completed as per duration by the guideline. The mainstay, I think, will still be surgical drainage. The main reason why we need to drain the septic joint is because the product of the white blood cells that actually produce all the chemical mediators that may damage the cartilage. So we need to clear up the joint. For the large joint like the knee, we can join the joint lavage. In adult, we may do it arthroscopically, but I think at the hip, especially in children, we may need to do an open surgical drainage and performing a hip joint arthrotomy to clear the affected joint. Okay, go to an example of a case. I've first seen the case quite some times ago. This was actually a 2-year-old boy who actually was referred to our center following a history of fever, and then refused to walk with a swollen thigh, but complaining of like a knee pain. Right, so you can see from this referral, he started with just a dry cough, and start to see a general practitioner, but was given medication, but came to us about 6 days after the onset of the event. Okay, so this is a child. You can see how painful or how miserable the child is, and you can see also actually the right thigh here is swollen and actually is held in flexion, which is the position of comfort for any joint joint pain. So I think looking at this with the joint swelling, pseudoparalysis, as well as the clinical features of inflammation over the affected side, and on top of that, the patient is having a high temperature, I would say there is no doubt that actually this child is having a septic arthritis of the right hip. Okay, following which we did some blood investigation. The total white was 23, the ESR was 109. We did blood culture. Somehow rather the blood culture result come negative. I think from the literature we do know actually the blood culture is not so sensitive. I think only up to 50% that can get a positive result from blood culture. But if we were to take the blood culture, it's most important that we take the blood culture during the peak of the febrile event. Whenever patient had a spike of temperature, so that will be a good time to take the blood culture. But as we saw, I think in children it's not that easy for us to take the blood culture. Okay, so a radiograph, you can see actually the joint space on the right side here. There's haziness as well as abnormality, but if we are not familiar with this type of so-called radiograph, we might miss this, right? And we might not actually think that actually the joint is actually having some problem. Okay, we sit as a patient for ultrasound, and you can see the ultrasound from the right femur, the right hip joint, there will be increase in the joint space as compared to the left side, and this is reported as well, where actually the joint effusion is being reported, and that's where the limitation of the ultrasound, right? The ultrasound might always tell us whether there is a effusion or not. Some may report of periosteal elevation or debris in the joint that's suggestive for septic arthritis. But it's also mainly depends on the person who's doing the ultrasound. So at the end of the day, I will say again, all the investigation, the blood investigation as well as the radiological investigation is an adjunct to help us to diagnose septic arthritis, but the diagnosis of septic arthritis remains through clinical assessment. Okay, so this is the child in the OT. The hip is in flexion, FC, and we did an anterior approach for the hip joint to drain and deferred straightaway pus coming out from the hip joint. Okay, we did a joint lavage, and we following which I think we close the skin. Nevertheless, what I've learned from this case is that we started this patient with closed saline initially, because we thought actually the most common organism is still Staphylococcus aureus. That's why we start with Darussalam. And nevertheless, 2 days after the first drainage, we got pus pouring out again from the hip joint, and we have to go in again and clear the joint again. And if you notice, the color of the pus that coming out from the affected joint here is not so yellowish. I think that actually gives us an indication that we might not actually be dealing with the Staphylococcus, the typical Staphylococcus aureus, where the pus usually is quite golden yellow in color, right? And true enough, actually, when we send it for culture and sensitivity, the organism that we get is actually Streptococcus pneumoniae, which is sensitive to amoxicillin clavulinate and resistant to the cloxacillin, right? So this is a child after antibiotics, after we change, after the second drainage, as after we change the antibiotics to amoxicillin clavulinate acid. I think by almost 2 weeks of IV antibiotics, the child start to be amiable, and you can see here he is more comfortable. What's so special about this child is that 6 months before this event of septic arthritis, this child had a cochlear implant implanted at his temporal bone, and the cost of the cochlear implant is 60,000 ringgit. And just imagine if we do not tackle the septic joint aggressively, it may actually, cause problem to the cochlear implant. Okay. So there you are. So this is the intraoperative IR images to check the stability of the joint after we do the drainage, and you can see the joint space here is much reduced. And this is the X-ray 3 months after arthrotomy. Again, you can see the Shenton's line is broken. Most probably this indicates some damage to the epiphysis. As we follow up this patient further, this is 9 years after the drainage. And you can see this patient in this auto long leg radiograph, there's a limb length discrepancy between the right lower limb to the left lower limb. I think this patient last seen about 2 years ago at the age of 12 years old, and he has about 3 centimeter limb length discrepancy. However, the range of motion is quite acceptable. I bet there is an limited abduction, as you can see from this radiograph. And we did suggest and offer the patient regarding contralateral hemiepiphysodesis to catch up the limb length discrepancy, or we might do a lengthening procedure if there is a need. But I think the patients are not ready for that procedure, so just being treated with a shoe raise. This is another child presented to us with 3 centimeter limb length discrepancy post-septic arthritis. And this is from another view when he is get older. On the right side here, you can see the Trendelenburg, all right, following the septic arthritis, and this is the outcome of the septic hip. This patient actually was referred to us from somewhere else with this type of problem where the right hip is already dislocated. Yeah, and this is the range of motion that we have, almost quite acceptable. And this is just to show you on the possible sequelae of septic arthritis in a child. So in the first case, you can see the hip joint is actually still stable, but in the second case, you can see the head is gone, the hip and dislocated, and the right hip joint that is actually become unstable. In terms of management, I think this is a good article that everyone can read. It was published quite some time, but I think it's still relevant. And when you talk about the sequelae of septic arthritis in a child, the Hyomka classification is always being referred to, and it's based on the the outcome of the septic arthritis itself, whether the hip is stable or the head is gone, that making the hip joint very unstable. I think Prof. Choi from Korea also modified the radiographic classification based on the hip deformity, and I think Prof. Choi classification does help in terms of determining what type of surgical procedure or management that can be done, right? And one of the procedure that can be done would be actually trochanteric arthroplasty. If the greater trochanter epiphysis is still available, we can do a varus osteotomy and put the retrotrochanter back into the joint and make it functioning like a hip joint. To be honest, I myself personally, I haven't not done this procedure. Maybe the seniors like Prof. Lee and the others might help and advise us on this type of procedure. Another late construction procedure that can be offered to this type of problem in patient with septic arthritis would be the pelvic support osteotomy. This is a bit complex procedure. I've only done it once, and I think personally to say that actually performing a pelvic support osteotomy, the outcome is quite favorable to the patient as well, where they get back the limb length discrepancy, the proximal femur is quite stable, and they can almost like functioning near to a normal person function. Okay. The others, I think we can do it would be some sort like hip arthrodesis if there is need to. But last but not least, I think at the end of the day, just like the patient in second case, the patient does not want anything to be done. All right, so I think the patient now is already 18 years old, so he managed with the limb length discrepancy that he has, offered PSO, but the parents, I think, and the patient himself, I think, are not open to that type of procedure yet, and they are happy with whatever that they are now. Okay, so at the end of the day, I think whatever that we have from the sequelae of the septic arthritis, the management will much depends on the functionality of the patient as well as what does the patient want. Okay. Take home message, I think septic arthritis is always an emergency, especially in a child. The diagnosis is mainly clinical. That management includes the use of antibiotics as well as surgical drainage. Our aim, especially in the hip, is to get a joint stability, and late reconstruction of the hip joint would be an option if patient requires an intervention. Okay, I just want to share with everyone here from the AOA. This is our new UKM Children's Hospital, right beside the current HUKM. Inshallah, we'll open it up by next year. We actually started operating somewhere in March, but because of the pandemic of COVID-19, this hospital has been changed to manage a totally Cat 4 and Cat 5 COVID-19 patient for almost 4 months. But I think hopefully by next year we can open up this hospital. Just to share that we have the facilities of hotel here as well as convention center. So maybe if we can do something, we can invite everyone from the AOA fraternities to have some form of meeting here in this new hospital. That I say thank you very much.
Thank you very much, Dr. Halim Rashid, for a very comprehensive review of septic arthritis. When you are faced with a child who cannot mention his symptoms, it can at times be a difficult decision to make, and you have very well taken us through the various indicators. We have 2 questions from the attendees. How do we differentiate clinically whether the distal femur osteomyelitis has spilled into septic knee arthritis in clinical setting of a young child?
Okay, I think again, in patient with septic arthritis of the knee, the possibility of osteomyelitis of the distal femur must be there. As you know, the joint line, the capsule lining in the knee joint did cover the metaphyseal part of the knee joint. So it can be both, whether it's a septic arthritis causing distal femur osteomyelitis if we don't treat the septic arthritis very early. But I think most of the time there is a possibility of a distal femur osteomyelitis that result into the septic arthritis as the main presentation of the distal femur OM in a child. I think so. So I think to differentiate clinically is not that easy, but I think especially the radiograph might not be so helpful in the early phase of it. So we need constant monitoring and to see whether there is any changes at the distal femur as well when we treat the patient with septic arthritis of the knee.
Yeah. Thank you very much for that. The next question is, do we need skin traction to prevent hip joint flexion contracture in caring for children with hip septic? Would you use it regularly?
It depends on the patient. If the patient does not move, refuse to use the hip joint or things like that, and we were concerned that the hip is rather unstable while initial treatments, I always put the patient on a skin traction for a while. Right. So I think it depends on the clinical situation of the patient. If the hip is stable, you don't really need a skin traction. But if you think your hip is not that stable and you need to immobilize the joint for a while for comfort or things like that, I think a skin traction will be very helpful.
All right. And another question, something you have addressed, I suppose. How long about should be the duration of antibiotic in osteomyelitis?
Okay, osteomyelitis, I think in osteomyelitis, I would say that you need a bit longer duration of antibiotics. As I've shown you at least in Malaysia, the guideline says that actually for osteomyelitis, you may need to give the antibiotic up to 4 to 6 weeks as compared to septic arthritis, which is slightly shorter. So I think for OM, the current recommendation between 4 to 6 weeks, I think. Yeah, for osteomyelitis.
Can I ask one question?
Please,
Yeah.
Dr. Philip.
I'm Dr. Philip from Brunei Orthopaedic Society. My question is about osteoarticular infection in children aged 6 months to 4 years. Recently, in many countries like UK, Switzerland, France, and USA, the most common causative organism is Kingella kingae rather than Staph aureus.
Yep.
In Brunei, we haven't diagnosed any case of Kingella kingae so far. We don't have the real-time PCR assay specific for Kingella kingae. So my question is, what is your experience in your practice and what is the incidence in other ASEAN countries?
Okay, Dr. Philip, I will tend to agree with you. I myself have not seen one, the Kingella kingae, but in our setup, I think Staph aureus or strep is still the most common organism. But if let's say the treatment is not working as per expected, and especially when we started treatment and the culture and sensitivity come back as negative, we may need to think about Kingella kingae. But the thing is that we need to liaise with our lab, with the microbiologist on how to get the culture for Kingella kingae, because they need a special culture for it. In my setup, I think we don't have that PCR for Kingella kingae because the incidence as much you say is very low at the moment. So what we did was actually we asked for a help from our microbiologist to look for it in cases that that not respond well to the usual treatment of septic arthritis. Maybe Prof. Lee could advise us on that, Prof. Lee. On this Kingella kingae.
No, I think you've said everything. It's okay.
Thank you very much, Dr. Halim Rashid. Could I request?
You said
I request you to answer the other questions offline or separately so that we can carry on with the next lecture.
Yep.
Thank you very much for your presentation.
Yep.
Moving on, our next speaker is Dr. Pang Hee Ni from Singapore. He's going to talk to us about arthroplasty-related infections. I have the pleasure of introducing him. He is a senior consultant and director of adult reconstruction service in the Department of Orthopedic Surgery at Singapore General Hospital. His current appointments include clinical associate professor of Duke NUS Graduate Medical School and adjunct assistant professor of NUS Yong Lu Lin School of Medicine. He has pioneered the use of minimally invasive direct anterior approach to total hip replacement and has also helped set up the Southeast Asia's very first outpatient protocol for total hip replacement. He is very much involved in research and has more than 50 publications. He has strong interest in outpatient arthroplasty, value-driven care, robotic surgery, wearables, and telemedicine for arthroplasty. Dr. Pang, the virtual podium is yours.
Thank you, Dr. Pande, for the kind introduction. Good afternoon, everyone. Thank you, AOA and Dr. Pande, for the opportunity to share my experience in infections in arthroplasty. I work in Singapore General Hospital. We recently celebrated our bicentennial anniversary. It was supposed to be a big event. It was a big event, but we would have hoped that it would be a physical one due to COVID, it was done virtually. We operate about 3,000 joints every year, and unfortunately, 1% or up to 1% would have some sort of infection. Let's start with a case before we move on to discuss the various investigations and treatment modality. So this is a 70-year-old male, fairly independent, diabetes mellitus but well controlled, ischemic heart disease treated, and then previous thoracolumbar spine surgery. Right shoulder hip replacement was done. It was complicated by delayed wound healing, and the wound managed to heal in the end. 3 months post-operative, he complained of right hip pain persistently with limb length discrepancy of 3 centimeters. X-rays were done, and he was told that there was medial migration implant. It was prescribed custom orthotics for the limb length discrepancy. 6 months after the next operation, a partial revision hip surgery was done. Femoral stem was replaced, the cup was not changed, and the intraoperative culture grew MRSA. 5 years after the first operation, X-ray showed loosening of the cup, and he was prescribed bisphosphonate, and this resulted in a contralateral atypical fracture of the femur, and this was nailed. At our first clinical consultation, which was about 8 years after the operation, he presented with right hip startup pain, which was progressively worsening, centered over the groin, and he was unable to ambulate without analgesia. On examination, the right hip did not show any sinus tracts. The previous scar was healed, and there was no surrounding cellulitis. However, there was limited internal rotation due to pain, and there was a limb length discrepancy of 1 centimeter. Total wide CRP were not elevated. ESR was a little bit on the high side, 35. We did an ultrasound guided aspiration, and this gave a positive synovial result. And it was also noted unhealthy seroprevalence fluid on anterior hip joints. Cultures, aerobic, anaerobic, TB, gram stem were all negative. This is the X-ray, so you can see that the femoral stem is well fixed. The cup, cemented cup, was loose with radial loosened lines, all 3 zones. Right. So, in view of the positive synovial test, he underwent first stage revision to the hip replacement. We also encountered seroprevalence fluid in joints, which was in line with what the ultrasound aspirate yielded. We repeated another synovial test. It was positive. Therefore, the femoral implant was everything was explanted, and the Exotex CN spacer with a transpin extension was implanted to protect the ETO. Intraoperative culture grew Staphylococcus epidermidis. Okay, so this is from deep tissue culture. It's important to send many tissue samples for cultures. Right? And with antibiotic therapy, the ESR managed to normalize. The CRP managed to normalize, but the ESR remained elevated. So in my practice, as long as the ESR show the downward trend, and the ESR may take a longer time to normalize, I will do a hip aspiration, and if culture is negative, I would proceed with a second stage implantation. This patient underwent second stage revision surgery with a cartilage construct on the socket side, and a Wagner stent on the Wagner is a titanium tapered stent from Zimmer. It's a so moving on, we discuss the prosthetic joint infections. Okay. The risk factors are obesity, smoking, alcohol, drug abuse, and revision surgery. So in this case, we have revision surgery, and the patient had diabetes. The incidence is anything from 0.3 to 1.3%. The common organisms are Staphylococcus, MRSA, methicillin resistant Staphylococcus is getting more prominent. If it's early, 1 to 3 months after the operation, usually it's associated with wound complications. In this case, there was a delayed wound complication, delayed wound healing. If that is a high risk for wound infection. If it's delayed, it's usually indicative of biofilm formation, and we have to consider explantation, right, to remove the biofilms totally. With late onset, which is 12 months from the operation, we consider low virulent, insidious onset microorganism, or acute hematogenous PJI. The history, usually there's pain, stiffness, fever, and swelling, and we ask for recent or active bacteremia, especially with regard to the pneumonia, urine, or ulcers, infected ulcers in the lower limbs. Physical examination, we are looking out for sinus tract, inflammatory changes, and limited RM stiffness. Usually, if the implants are loose, they have loss of startup pain. Instability, such as hip dislocation, could be a symptom of PJI. So this is the criteria, Musculoskeletal Infection Society diagnostic criteria for prosthetic joint infection. Major criteria are commuting sinus tract or 2 positive synovial cultures. Right? Any one of these with 3 of the 5 minor criteria would suggest PJI, prosthetic joint infection. And these are the minor criteria: ESR-CRP, white cell count on aspirate or a leukocyte acerate strip, elevated polynuclear cell count, and 1 positive synovial culture, or more than 5 polymorph nuclear cells per high power field, X400 magnification times magnification. This is the modification by Pavisi in 2018. Essentially, the major criteria are the same. He added the Sanabasia test, which is the alpha defensing, and he stratified the minor criteria. So the important minor criteria are synovial cell count, or leukocyte acerase, or alpha defensing Sanabasia. So if you have you don't have enough fluid from your aspirate, it is recommended that in addition to sending for cultures, you use the limited amount of fluid for synovial cell count or Sanabasia test kit, the alpha defensing. These are the 2 most important minor criteria. If you have a dry tap, then you rely on intraoperative assessment evidence. And this is either positive virulence, as demonstrated in this case, or positive culture, which is also demonstrated in this case. Okay. So this is the Pavisi WAOS clinical practice guideline. Okay. ESR-CRP interleukin-6 have strong evidence, right, with high sensitivity and specificity. Okay. Interleukin-6 is expensive and not usually done here, but most labs will do ESR-CRP. Tumor necrotic factor alpha and peripheral blood leukocyte counts, they are not as strongly sensitive or specific. The gold standard in diagnosis of PJI is that of joint aspiration, whether you do an ultrasound or CT-guided aspiration. And you send them for Sanabasia test kit, as well as cell counts, differential counts. It is important to maximize the yield from this aspiration, because if you don't have a bacterial pathogen, then half the battle is lost already. Right? So it's important to maximize the yield, and this can be done by suspending antibiotics 2 weeks before the cultures. What I do is, once I aspirated the joints, I would inject the aspirate immediately into blood culture bottles. Right? So if you leave the aspiration on the table for a while, the fastidious organisms will have died, and you cannot culture them anymore. Similarly, if you put them in a specimen bottle without storing it, it's also these organisms can die very easily as well. So you won't be able to do anything. Radiological evidence would be quite late, because the signs of osteolysis, parasite reactions, and implant incident usually happens in the very late stages. PET scans and wound scans have weak evidence. CT or MRI, CT scan is good to assess for wound loss before the revision surgery. MRI to assess for collection if you want to aspirate. A frozen section has strong evidence, but you need to know which are the representative areas to send for histology, and you also need to have pathologists who can do the staining properly and give you a proper report. Okay. It's important to take multiple tissue. I take at least 5 to 7 tissue from many sites, right, different areas for cultures with prolonged incubation. Okay, so these are the evidence for ESR and CRP. Strong evidence for ESR and CRP, 97.6%. Synovial cell counts and percentage neutrophils are also very important. I take the cutoff as 2000, 1007 for WBC and 65% for polymorph nuclear cells. Okay, this will give you 94% sensitivity and 88% specificity. Alpha dependency is getting very popular nowadays. However, it's expensive, right? The good point, the advantages are the test is unaffected by prior antibiotics, ongoing sepsis and inflammation, and there's rapid identification. Within 10 minutes, you will have results. Okay. Unfortunately, the results may be affected by patients with active inflammatory arthritis and gout. This will give you false positive readings, or if you have a bloody tap, that would also give you false positive readings. Leukocyte esterase is an enzyme secreted by neutrophils. The test strips are used in synovial fluid. We use it for the UTI as well. Advantages are cheap, rapid, and it's a convenient test, but disadvantages are is affected by active inflammatory arthritis and gout, similarly resulting in false positive readings. Sonification is very useful to maximize the yield from our explanted implant. So we pass low frequency ultrasound waves over prosthesis to detach the biofilm organisms. This can increase the yield by up to 30 times. After the investigations, we move on to the treatment modality. So there are 5 surgical options: debridement, antibiotics, implant retention, single stage, 2-stage revision, right? Arthrodesis, and amputation. Okay. So for example, a patient who is suitable for debridement, antibiotics, implant retention will be this patient with 1 week post-op persistency discharging wound. Okay, so you must be very aggressive with wound discharges. If it's discharging by 1 week, spare no attempts to debride it and send for cultures. Okay. Right? So in the debridement, you will do a proper debridement, and these are the biofilm busters that we use in our institution. Chlorhexidine, acetic acid 0.5%, hydrogen peroxide, 5% iodine. This will help to eliminate aerobic, anaerobic, fungal, and mycobacteria. Postoperatively, rifampicin is also another biofilm busters. We keep them on rifampicin for a while starting them on or continuing them on antibiotics that can target the pathogens. So in this case, the culture grew Pseudomonas aeruginosa. The patient finished 6 weeks of IV antibiotics, and he was disease-free thereafter. So the results for debridement, antibiotics, and implant retention, right, in this study is up to 89.2%. But these are the people with early infection, right? These are patients with about 1 week of wound discharge. They go in early to debride, so the results will be good in these cases. Okay. In these two other studies, right, the results are not so good. About 60% success rate, and the cases that failed there are the Staph aureus infection, right? Staph aureus infections are not good for there. Okay, in our paper, we have 106 patients. The success rate was about 70%. We found the predictors of failures were MRSA infection, pre-op ESR, and repeated DARS. So if you have failed one DAR, implant retention is not advisable for you to repeat another one, because you're just delaying the inevitable of 2-stage operation, and you are allowing the biofilm to form even more. So the success for the factors for success for there will be a short duration of symptoms, right? Factors for failure will be Staph aureus infection, patients with poor ASA. For a single stage, this will be an example of a patient who is stable, 5-week post-op, complaint of persistent right knee pain and CRP being persistently elevated. Okay. Knee aspiration grew Staphylococcus aureus, okay, from the knee tab, and she underwent a single stage operation. So a single stage operation is not one operation, it's actually 2 operations in one. For the first part, all the implants are explanted. Okay, we give a good wash with the ribofilm blasters. Okay, and then we stitch up the patient, right, to redrape, regown, and use another set of instruments for the second stage, for the re-implantation. Okay, so it's actually a 2-in-1 operation. Right? It's not advisable to use the same instrument for your explantation and your re-implantation. Okay. Now, so the following patients will require 2-stage. 67-year-old patients with non-tuberculous mycobacterium. This is a very aggressive bacteria, very different from your TB bacteria. This non-tuberculous mycobacterium will require multiple repeat spacer exchanges. And you see, even with the repeat spacers exchanges and the IV antibodies, he developed patellar pathological fracture from infection. So this patient required a year of antibiotics, repeat stage 1s, before we finally put in the revision implants. Another case for 2-stage, 65-year-old multi-organism PGI. You can see that there's a lot of osteolysis, there's loosening of the implants, right? Okay, so in this case, we have a very unusual organisms, right? Unusual organisms, and the patient will require a 2-stage procedure right before we put in the revision implants. So what is the evidence out there for single versus 2-stage revision? In this meta-analysis, there's actually no difference if you choose the patients wisely. No difference in outcomes between a single stage and a 2-stage procedure if you choose your patients wisely. Okay, right. So these are the patients requiring arthrodesis, MRSA, PJI, patellar rupture, extensor mechanism loss, and massive skin necrosis. Right, so you need to remove the implants. I use a nail to arthrodese the knee first for the flap to take, and once the flap is taken, infection is cleared, you can proceed with arthrodesis. Can be done using an X-fix, can be done with plates, or you can use an intramedullary nail. So this is a 2-year post-op arthrodesis. Right. And finally, the amputation cases, right? The 70-year-old female, eczema, very poor skin condition, diabetes, and she had a megaprosthesis with periprosthetic infection. Tissue cultures have been growing Staph aureus and fungal. Fungal bacteria is another bad news. It's very hard to clear. So this is a megaprosthesis. We try to do a limb salvage procedure, remove the implant, and use a static spacer, but we were unable to get rid of the infection. In the end, she had to go for an amputation, right? So lastly, this is our technique for treating infected periprosthetic fracture with protrusio. Okay, you can see that there is a periprosthetic fracture around the bipolar implant, and there's a protrusio into the pelvis. Right? Tissue cultures grew anaerobic organisms. We reported this technique, infected THL, Paprovsky 3 defects in the socket after explantation. What we did was during the first stage, when we removed the implants, we gave a good wash, we bone grafted the protrusio with cancellous bone chips. Then we put a cement spacer, cover the bone chips and hold it in place. And during the second stage, we retained the induced membrane over the bone chips and used hemispherical cups without a need for augments or cages. So this is an example of how it's done. We put some bone grafts in the protrusio with a cement spacer, and after that, we put in a hemispherical cup without any augments or cages. And 5 years post-op, you can see the remodeling in this case. Okay, this 1 year, 5 years post-op. So in summary, it's always important to have a strong intestinal suspicion for infection. If it's painful, you will try to exclude infection. Right? Debridement, implant retention, antibiotics for useful for early post-op infections. Be aggressive with the wound debridement. If the wound is discharging, be aggressive going early to debride the wound. Acute hematogenous sitting will be top of your mind, right? is appropriate for implant retention. Single stage 4, known organisms, good soft tissue cover. 2 stage for difficult organisms such as fungal infection, non-tuberculous bacteria, MRSA, right? And if you have soft tissue loss. Arthrodesis for sensor mechanism losses and amputation in my practice is usually after two stages, right? So thank you for your attention.
Thank you, Dr. Panghini. Can you hear me?
Yes.
Right. Okay. I think it's a very interesting talk on the arthroplasty-related infection. I think some of the things that I picked up from your talk is actually about getting samples.
Yes.
I know there are different consultants I've worked with, and they have different way of collecting samples. And you said you've collected as many samples as possible. For example, in the hip, which part of the joint would you actually collect samples from?
Okay. So right. So the hip is a deep-seated organ. If you're talking about aspiration, right, I would recommend either CT guided or horizontal guided aspiration for infusion. Now, if you're talking about during the explantation, intraoperative assessment, what I will do, so intraoperative, I will send this fluid, as much fluid as I can get from the hip joint, right? And I'll inject the fluid into blood culture bottles, right? Aerobic, anaerobic, and fungal if there is enough fluid. Subsequently, I will send tissue for cultures as well. The tissue will be from the acetabulum, right? Will be from the membrane over the socket. In the femur, it will be intramedullary canal, right? And membrane as well. And lastly, bone pieces, right? Acetabulum from the acetabulum as well as from the proximal femur. So as many specimens as possible, as many different types, bone, fluid, tissue. Necrotic tissues are not so, dead necrotic tissue are not so useful because it's already dead. You may not be able to get much yield from them. And as for many sites as possible.
I see. All right. And then secondly, you did mention about the DARE, and you use a combination of chlorhexidine, acetic acid, hydrogen peroxide. Is there a certain percentage or how much you actually use chlorhexidine first, or secondly by acetic acid, or is there any combination of, like, firstly I use iodine and then followed by hydrogen peroxide, or just a mixed bag of everything, just wash it in?
Yes, you can mix. You can mix anything, but just be aware or be careful of not mixing acetic acid with iodine because it will cause precipitation.
Yeah.
So what I do is that I whichever paint bathroom master I use, I will soak it for a while, 2 to 3 minutes, and then followed by a wash. Okay, and the wash will be saline with gentle infiltration. Once I wash it, I debride again, and I put in a second bathroom master, and then wash it again, debride again.
Right. Okay. And I think, last but not least, I think very common in Brunei we see is a lot of ACBAs. Do you have any experience on getting infection from ACBAs for all these prostheses?
ACBA, can I just confirm that is like Acetobacter
baumannii is very multi-resistant, just like an MRSA.
Yes.
It's very bad.
Yes, that's very bad infection. And usually these are the people with previous surgeries done and poor comorbids, prolonged stay in the hospital. So the previous case, the one requiring amputation, that is that she grew this Acetobacter baumannii at one point. This is a poor prognosis, but if you want to try limb salvage, then it's multiple spacer exchanges, and you have to explain that you may have to have multiple two stages. Right? And my own threshold is after two stages, then you have to offer amputation.
I see. Yeah, I think for us in Brunei, probably the easiest way to get out of a hospital as early as possible, really, just to offer amputation, I guess. They can't afford to stay too long in the hospital. Anyway, thank you very much, Dr. Panghini.
For one more question.
Yeah, okay. Sorry. Yes, Dr.
When you say the rate of infection is 0.3 to 1.3, person, is there any standardized period of follow-up? Because if you follow up for longer period, obviously the hematogenous infection will be much more. So
Yes.
is there any standardized period for which 5 years you follow up, anything like that?
Yes. So, Dr. Kora, that's a very good question. Right? When we advise them 0.3 to 1% kind of infection risk, these are for the good patients, healthy patients. But this infection risk stays with them throughout their life, unfortunately. So, each of them, with a 1% risk of developing infection every year. In my counseling for them, if they really ask in detail.
And one more thing, can you give us some tips on how to prevent these infections? Like some people, after the primary preparation and draping, they once again paint with iodine. And some people have a lavage with weak iodine or chlorhexidine. Some others inject the joint after closure with vancomycin or tobramycin, like that. Do you have any particular tips?
Okay. I think we can go with the publicity guidelines now. The strong evidence would be, for example, using alcohol kind of cleaning solution. I personally will use iodine, soak iodine, the 5% iodine that publicity recommended to soak the joints at the end of the procedure, about 3 minutes. There's no evidence for Vanco powder, right? The Vanco powder is more for the spine deformities correction. And of course, lastly is your IV antibiotics. Now, most of the time, the teaching is IV antibiotics for 24 hours, and this is the consensus. But there's been increasing evidence of using prolonged antibiotics for a high-risk patient. Right? For example, if you feel that this patient has poor diabetes, poor skin, and you want to give a longer duration of antibiotics, that could also reduce your infection risk. Lastly, the wound closure, the wound dressing, right? So there are many different forms of wound closing. The real evidence would be for those incision drainage, the vacuum-assisted kind of dressing, but it's expensive, and there are also complications related to it, such as blistering, right? So I think it's important to make sure that they take care of the wound. If it's discharging, be aggressive with the wound debridement, right? And make sure that they don't keep the dressing and soak the dressing.
Okay. All right. Thank you, Dr. Panghini. I think we have to carry on for the next speaker.
Yeah.
Thank you.
Yeah.
All right. Let me try to share my screen. Let me do that. Share. Okay. Now I'm gonna share our screen. So right, okay. So sorry for the delay. I have something technical issue with my computer. Anyhow, all right, we'll carry on with our lovely evening. So our next speaker is actually Dr. Rahyussalim, right? So Dr. Rahyussalim, MD, PhD, is a lecturer and a spine surgeon at the Faculty of Medicine, Universitas Indonesia, Cipto Mangunkusumo General Hospital, Jakarta, Indonesia. Dr. Rahyussalim is obtained the title of General Practitioner, Orthopedic and Traumatology Specialist, and PhD of Medicine in the Faculty of Medicine, Universitas Indonesia. Currently, Dr. Rahyussalim served as Manager of Research and Community Service at the Faculty of Medicine, Universitas Indonesia. Until now, he has received a grant of approximately 6 billion rupiah. He has produced 83 national and international publications. Majority of them are indexed by Scopus, and 21 of them are by PubMed. 50 copyrights, 4 draft patents, 4 medical books, and actively writing medical articles popular in the media and on the website www.rahyussalim.com, as well as speaking at more than 100 symposiums, seminars, conferences at the national and international level. I would like to welcome Dr. Rahyussalim to our virtual podium to educate us on musculoskeletal tuberculosis. Please, Doctor.
Okay, thank you, Dr. Khairul. for your introduction, and good evening for all the panelists. I would like to thank committee who invited me to speak here, and also for my friends, Dr. Andika Yudhistira has also introduced me to this very important forum. Let me share. Okay, actually, I want to talk about the spinal TB infection because we have so many cases of TB spine infection in our country. That our Professor Subroto has developed some total treatment, and after until right now we are developing this method with multiple approach of mechanical, chemical, and biological in total treatment, especially for spinal TB infection. I think we all know that infection is defined as infections in the vertebral body, intervertebral disc and adjacent paraspinal tissue, and also it's able to cause significant pain and disability, and become a world problem also in our country, in Indonesia, I think. And one of the most common spinal infection is in my country, actually TB infection. As we know that the most common cause of bacteria are Mycobacterium tuberculosis, and actually the permanent neurological disability is a very important issue in my country to be a complication or the rest of symptom which should be treated well in my country. So we know that repercussion of TB spine actually, from literature, said that if we don't debride, if we debride TB without TB drug, there is mortality 70% and decrease if we do debridement with the TB, and if the TB infection with neurological deficit, the mortality will increase until 60%. We know also that paraplegia and quadriplegia is also the complication that sometimes very important sign in our country, in my country, and also the deformity, kyphosis, and the most dreaded complication of the TB spine infection. The major risk factor for increasing this deformity, actually, of course, the extensive involvement of the vertebral body. So in my country, based on our 20 years follow-up of patient, if we don't treat the vertebral body defect more than 2 vertebrae, we will find the pseudoarthrosis and cannot make fusion of spine. So if we do a spinal instrumentation, the implant will be failure. We have 25% case with this extensive involvement of the vertebral body. So I think we are always to develop our system to do this problem. So in the total treatment means that introduced by Professor Subroto Saparan in 1984 at Chittawee Hospital, has the philosophy of a guide to management of TB by dividing 10 treatment, and the aim to cure, to stabilize, to relieve pain, correct the deformity, and restore the function. So I think it is the very important aim of our treatment. And the important of this aim are allow patient to return to their social, family, and work environment. So in the concept of, or in the philosophy of total treatment, which we have developed, are how to treat the patient all over patient life. Not only one shoot at the first, but also in the total life. So that's the meaning of the total treatment. So we can see the patient back to and come into their social, family, and environment. What was the strategy? So yeah, we have 14 problems faced by patients with tuberculosis spondylitis that must be identified. The 14 most problem are general condition, instability, lesion, multiple lesion, deformity, collapses, painful infection, fracture, progressive kyphosis, neurological deficit, cardiovascular disorder, impaired lung function, socioeconomic problem. Of course, it is especially in our country. And sometimes we have the problem of psychogenic problem. So the first patient come to us, we should know this problem first, and then we make a strategy to this. The stage identification and clarification, and always make a list of treatment modalities and make a customized problem list with appropriate treatment and look for the most suitable treatment option. So many doctor in many spine surgeon, for example, should be treat and should be do this step of stage. Identification problem, clarification, make a list, and custom the problem list, and make appropriate treatment, and look for the suitable treatment. So there are 10 alternatives actually. Yeah, they are should be actually based on the lesion type: minimal, anterior lesion, anterior posterior lesion, or anterior and or posterior lesion. We should evaluate the patient condition, and the last, the right column are how to make a strategy to treat all this problem identification. So after we make a list, then we do some and develop multiple approach. We have 5 modality-based management approach. Chemical, of course, we need to give some chemical, drug, and many. Physical, sometimes we need to put some support. Psychist, of course, we treat this. Mechanical, doing surgery, open, minimal, and many kind of approach. And of course, I think it is the future medicine, biological. It's mean right now we have also stem cell and metabolite product to put on lesion. So this approach can be single or also can be combined. So this multiple approach, they aim to reduce complication during management of spinal infection and to restore spinal structure, of course. We should consider 4 aspects: biological, mechanical, of course, electrophysiology, and risk and complication assessment. So for aspect, we have 4 aspect multimodal approach. biological, biomechanic, and of course, we evaluate risk and complication. Yeah. What is the biological aspect? Yeah. We need killing bacteria with any kind of approach, antibiotic, yeah, the bread demand. Sometimes we need auto transfusion, and we put tissue engineering. Mechanical aspect, anterior, posterior surgery technique, and of course we correct the deformity and makes the proportion of the body with the limbs better. Yeah. We don't do the we should make a proportion of the vertebral body which diminished before, and of course we make the spinal structure more strong. Every approach should be consider the function of nerve. Eh? We always check the electrophysiology aspect, and of course, yeah, everything related to risk and complications should be assessed. We have developed C-score. Yeah, it's mean spine surgery injury severity score. So if we are planning to do surgery, we should always whether this score or the prediction will be the severity of injury will be there will be make the condition bad or better. Yeah? So we think of our surgery will be make a good condition or not after surgery. So this is the diagram of multimodal approach. Yeah? This is the approach we should be considered: biological, biomechanical, electrophysiology, and risk and complication assessment, preoperative. Yeah, so we need to check killing bacteria, spinal support, general condition, brace, implant, and many. And then we check this whether everything will be work, preoperative, intra, and also early or delayed post-operative. Yeah. So in the total treatment, we should evaluate pre, intra, and post-operative, early and delayed. And we perform a diagnosis to make a mapping, of course, and obtain a list of problems and resolve this problem using the approach. Yeah. I want to show some cases with our this total treatment. Yeah. This is the case one is a 13 years old boy with TB of cervical and lumbar. Yeah. Actually, this patient has, you can see here, yeah, the mass. Yeah, I guess it is, of course, abscess. Yeah. Impaired balance and stiffness when walking, weakness in both extremity, and hard to eat and can't sleep well. So you can see, yeah, destruction on the C5, yeah, and you can see abscess at the level of C1 to C4. And if you see at the lumbar area, you can also the infection at the L4. Yeah. So, okay, we can see here, yeah, the abscess. Okay. So, of course, we check what is the problem identification and clarification. Yeah. Of course, we do physical examination, CT scan result, MRI. Yeah. And we check with what about the all level of the vertebrae. Sometimes we need to check this not only the vertebrae with the complaint, but also the whole spine. Yeah. and we make a list of the treatment, yeah, doing mechanical approach, abscess evacuation, chemistry, chemical, we do local antibiotic administration, of course, and then, sorry, this is not percutaneous laser, this is the common, but percutaneous aspiration of the abscess, and we give local antibiotic, we put on the abscess, and the next step, we should repair the defect in by putting the stem cell. Yeah.
1 more minute.
Yeah. We don't open this abscess. Yeah. We just take by aspiration. We can get until 100 cc. The step 2. Okay, sorry, this is I mean just putting at the L4, yeah, we inject the antibiotic to the lesion, yeah, and this is 2 weeks after our procedure.
Leher sakit ya? Leher sakit? Udah enggak? Ya ulang lagi skip.
Okay, the second case, 46 years old female.
Dr. Rahyussalim, you got another minute to complete, okay, please. Yeah.
Okay. Yeah. I think it is, but I want to show the last cases, I think. Yeah. This patient with, yeah. With more one defect of vertebral body, yeah. This patient with always failure of implant, yeah. Okay, and then we put stem cell and on the scaffold. Okay, and then you can see after this is the 4th surgery, because the patient has twice failure of the implant after the 3rd surgery. Yeah. Okay, the conclusion is actually the multiple approach of mechanical, chemical, and biological should be applied into overall total treatment of TB spinal infection, because we need to see the whole life of the patient. We want patient come to the social, and the treatment of TB spinal infection should be follow this step: evidence-based treatment, and problem-based treatment, and result-based treatment to define problem-solving targets. I think, thank you very much, Dr. Khairul. Yeah.
Thank you, Dr. Rahyussalim. I think it was a very enlightening talk. Just a question. I think I read recently about increasing anti-tuberculous resistance. When do you actually consider doing surgery? Or maybe initially you thought like, oh, I would like to treat this conservatively with minimal neurological deficit, with bone loss, with bone destruction. But when do you decide when you start thinking that the spine or the spine infection from TB is actually not responsive to anti-tuberculous treatment?
So in my opinion, the TB drug treatment just only 25% of the whole our treatment. So even though we have 1 or 2 cases with the TB drug resistant, we debride and take all the debris, and we do multiple debridement is enough to take all the infection. So we don't care about for the TB spine only, but I have no, I have no experience with lung TB, but the TB spine with drug resistant, if we do multiple debridement and just put the antibiotic as you, broad spectrum is enough. Yeah. So 2 cases with this approach, can solve this problem.
I see. All right. How long do you actually keep them with the, let's say you've done the surgery and it all well, nicely fixed. How long do you actually keep the anti-tuberculosis treatment for musculoskeletal bone involvement?
Okay. Actually, we don't give antibiotic based on time, but based on the culture. If we see the culture is negative, we can stop the antibiotic. Yeah. So sometimes we need to check more and many sites. And if you see the lesion still there, and you take the sample and check there is no bacteria, we don't need to put antibiotic there. But we need to refresh the tissue. Sometimes we put the biological approach. Yeah? We put a graft, and sometimes we put stem cell. I think it is work and very useful for treating the recurrent infection, and sometimes, yeah, the reinfection.
All right. Okay. Thank you very much, Dr. Rahyussalim, for your talk.
Thank you.
Excellent one. I think we have to carry on with, well, we're considering the time now. I would like to share my screen again. Share. Okay. Our fourth speaker is a colleague of mine, is Associate Professor Dr. Ketan Pande. He is going to talk about musculoskeletal melioidosis. Now, this topic is rather unique to the ASEAN region and not so much known to the other parts of the world. Even if I've asked my professor in Liverpool back then, and he hasn't got any idea about melioidosis. But anyway, this talk is going to be conveyed by my colleague, and he is working as a consultant orthopedic surgeon in Brunei since 2005. Dr. Pande is in the forefront of clinical research here with a special interest in melioidosis and osteoporotic hip fractures. He's also an associate professor at the Institute of Health, University of Brunei Darussalam, and the current editor-in-chief of Brunei International Medical Journal. I would like to invite Dr. Ketan Pande to deliver his talk on musculoskeletal melioidosis. Over to you, Dr. Pande.
Thanks, Khairul, for the introduction. Over the next 14 to 15 minutes, I would like to share with you our experience of managing melioidosis in general and musculoskeletal melioidosis in particular. We will first look at a few cases which illustrate what a typical patient of melioidosis presents with. This patient was admitted under the care of physicians, 49-year-old, known hypertensive. He had pancreatitis related to alcohol abuse. He presented with anorexia, polyuria, polydipsia, and was diagnosed to have diabetes. He had all the features of sepsis. He was picked up to have pneumonia as well as hepatomegaly, and clotting was altered. He was referred to us with history of right knee pain of 2 days duration. On examination, there was no effusion, there was diffuse tenderness, and the movements were painful. Plain radiographs were not very helpful. Ultrasound showed that there was cellulitis with subcutaneous edema, but no abscess collection. Over the next week, it developed into a frank abscess, and he underwent drainage of the superficial abscess around his leg and knee. As he did not respond satisfactorily to the antibiotics, MRI was requested 5 days later, which showed osteomyelitis changes in the proximal tibia and septic arthritis, as we can see in the slides below. He also had myositis changes in the posterior compartment of the thigh. There was some signal change in the femur, but it was thought to be due to edema rather than infection. A few days later, he was taken up for wound debridement when tibial drill holes were made to release the intramedullary pus. He needed another surgery for change of dressing, and during follow-up, these are the serial X-rays. He responded satisfactorily, but more recently is presented with persistent discharge from the tibial incision and he is awaiting another surgery to implant antibiotic-loaded cement beads. Another case was a 46-year-old Bruneian. He was a known diabetic, presented with fever, weakness, dry cough, and chills. Pus was aspirated from his left leg, and sometime later he had MRI scan, which did show some osteomyelitic changes, but the surgeon under whose care he was admitted opted to drain the abscess only after some time because he was systemically very unwell. Same story, as he did not get better, MRI was done, which this time showed a pathological fracture through the proximal tibia. He underwent another debridement of the left leg and thigh wounds, and subsequent MRI done few months later, as he was not responding satisfactorily, showed that he had an intramedullary sequestrum in the proximal tibia. Further surgery involved a cortical window and antibiotic-loaded cement beads. He underwent removal of beads a few months later, and at follow-up more recently, the pathological fracture has healed. He has a persistent lytic lesion, but unlike the first patient, he doesn't have any active signs of infection. The third case was a young Bruneian who was poorly controlled diabetic. He was already under treatment for melioidosis of the liver and spleen. He was also noted to have pulmonary involvement. His condition worsened, he has to be intubated, and during his admission in the intensive care, he was seen to have bilateral lower limb weakness. A neurological consult was made, various possibilities were entertained. MRI done to rule out any spinal involvement. On the left side shows that he had multi-level involvement of the vertebral bodies, but no cord compression, hence no surgery was done. It was difficult to obtain any sample to confirm that it was melioidosis, but in the context of his whole picture, treatment of melioidosis was continued, and the subsequent MRI shows healing of the lesions. While we are at the subject of melioidosis and possible tuberculosis, because the imaging studies can be very similar, we also had a case, a lady with neck abscess who was confirmed to be having co-infection by Burkholderia as well as tuberculosis, and certain common factors have to be understood. The risk factors for both these diseases are common. They are intracellular pathogens. In some cases, we see granuloma with central necrosis, much like tuberculosis. It is a chronic disease with relapse, and both infections are resistant to commonly used antibiotics. What is evident from these three cases I have presented is that there are certain common features. All of them are diabetics. They presented with sepsis, and pulmonary involvement was very common. Some of them also had splenic and hepatic involvement. In these cases, the musculoskeletal affection has ranged from abscess, septic arthritis, osteomyelitis, as well as myositis. Trying to know more about this condition, which was described more than 100 years ago, and the bacillus is referred to by different names, and the disease is also known as Whitmore disease or glanders. This is an interesting slide which shows the global distribution of melioidosis, and as is evident, most of the cases reported are from Southeast Asia. That's why we should be really concerned about this. And there are increasing number of cases being reported from India, and there are sporadic cases reported from rest of the world. If you look at the environmental suitability, we can see that most of the distribution is around the tropics, and that's not surprising because it is usually spread from contamination of soil or groundwater. It has a broad spectrum of clinical manifestation and can mimic other infectious diseases. That's why it's also called a great mimicker. It can affect almost all the body systems, and as shown at the bottom on the right, musculoskeletal system involvement ranges from 4 to 14%, involving septic arthritis, myositis, and osteomyelitis. Microbiology is very typical. You can grow typical colonies, and for more specific confirmation, the API 20 NE kit is used. The antibiotic guidelines are now very clear. The initial intensive phase followed by a long eradication phase is essential to prevent relapse. There have been quite a few publications from Brunei about this condition. Some of them have addressed specific organ involvement like pancreas or urogenital, and there was another case report. We got interested in this condition, and one of our first publication was with a very small number of cases. And we have continued our interest in this problem. We also had data for 10 years about antibiotic susceptibility, which confirmed that the susceptibility for meropenem and ceftazidime ranges between 90 to 100%. This graph shows that the sensitivity to ceftriaxone is very low, but it is well known that this is due to the method of testing rather than true low susceptibility. That's why we continue to use ceftriaxone in the eradication phase. By far the most comprehensive publication or data that we have from Brunei, or in fact rest of the countries, was published in this special issue of Tropical Medicine, which looked at global burden and challenges of melioidosis. So we published data from 2015 and 16 in that review article. And since that time, we have now about 311 cases. If you look at the demographics, men are more affected. The median age is about 48 years. Our youngest patient was as young as 2 years. If you look at the ethnicity, most of the patients are local Malay, but we have a considerable number of expatriates from different countries who are mostly working in the construction or agro industry in Brunei. This is a very interesting association already reported in some papers. When you look at rainfall and number of cases, the graph at the bottom shows the rainfall in Brunei Darussalam. And in the graph on the top, you can say that the number of cases more or less parallels the number of the months when we have higher rainfall. We also confirm this from data on rainfall in the various districts. For example, the district of Temburong has the highest rainfall, and of the 5 years that data we have, in 3 years, the highest incidence was from the district of Temburong. Moving on to the risk factors, compared to all other countries, I think we have the maximum number of diabetics who went on to get melioidosis infection, and the other risk factors are common like chronic renal failure, lung diseases, alcohol intake, malignancy. In some patients, we cannot find any risk factor. If you look at the presentation, the most common presentation is pneumonia, and about 20% of patients present with septic shock. In our series, musculoskeletal involvement was seen in about 18% of cases. A lot of patients have splenic and liver abscesses, and we had patients who had prostatic abscess, parotid, as well as adrenal abscess, which is very rare. Most patients who come in with sepsis would have their blood culture positive for the organism, and that's how in about 66% of cases, the diagnosis was made on blood culture. More important, I would like to draw your attention to the lower table here, which shows a very high mortality of about 30%. Even with the advances in diagnosis and antibiotic use, this number is quite high. Equally interesting is the relapse rate, which is seen in about 5% of cases. And of those 15, 11 of them had musculoskeletal involvement, suggesting that patients who have musculoskeletal involvement tend to have a chronic duration and more chances of relapse. When we compare our data with data from around ASEAN and more so in Australia, where it's known to be endemic, I think the cases varies depending on the study duration. One thing is certain that diabetes is the single most important risk factor, and osteoarticular presentation varies from 1.5 to about 18%, as in our series. Another common finding is the high mortality, as one can see in the last column. I would like to share some more cases and lessons we have learned from them. For example, this lady presented with an abscess around the elbow joint, and the question was whether the joint as such was involved. And MRI was quite helpful in ruling out intra-articular involvement, and we could focus on the drainage of the abscess without disturbing the joint. When we are looking at osteomyelitis and septic arthritis, I think we need to have high index of suspicion. For example, someone presenting with septic arthritis may have a very widespread involvement. For example, on the left-hand side, the distal femur is grossly involved compared to the case on the right-hand side who presented with septic arthritis, but the bony involvement is limited to the femoral condyle. This is very important to plan surgical treatment. And not all patients who have MRI changes have melioidosis infection. For example, this tourist from India who was visiting his relatives had pneumonia confirmed to be due to melioidosis. He complained of groin pain, and MRI showed high signal change in the iliac wing as well as the gluteal muscles. But the same area didn't enhance when contrast was used, suggesting that it was edema rather than active melioidosis infection. We have noticed myositis in most of our MRIs, but we have not really confirmed it by biopsy. But a more recent paper from Sri Lanka has reported on a case where they could obtain biopsy from the involved muscle to confirm it to be melioidosis. So this is another interesting area we want to explore now. In conclusion, it's fair to say that if you have a patient with unexplained sepsis who also has diabetes and pneumonia, there is a good chance that he has melioidosis. And the lessons we have learned from managing musculoskeletal melioidosis is that about 1/3 of patients with sepsis have musculoskeletal involvement. In our series, osteomyelitis is more common than septic arthritis. Patients who have osteomyelitis need multiple surgical procedures. Relapse is more common, and they need much longer treatment than septic arthritis. A lot of patients undergo washout because they are quite sick to have a formal major surgery like arthrotomy. But whenever possible, we feel that arthrotomy offers you better clearance of the infected tissue rather than a washout. We have had few cases who had to be taken back to theater for repeated washout or washout in the beginning, followed by arthrotomy at a later stage. The most important lesson here would be early diagnosis and aggressive treatment. And one should resort to MRI early in the course of the disease to plan the treatment properly. The high mortality continues to be worrying, and it's not only limited to Brunei, it's true for all other countries who deal with this very unique problem. I thank you for your kind attention.
All right, thank you, Dr. Ketan Pande, for that excellent and fantastic lecture on melioidosis. I very much enjoyed it. I can say that, I mean, obviously, I'm actually sitting on a patient as well at the moment with an ongoing melioidosis in the hospitals under medical ward at the moment, who had just survived ICU, he was very unwell and now presented with deep-seated gastrocnemius abscess and most likely melioidosis. He also developed a lot of other abscess collection in the abdomen, the spleen, and the liver. So I think in Brunei, I would say we have seen quite a fair number of cases like this. And I think maybe, you know, recently, I think in November is actually very rainy season right now. So I guess, yeah, the case for melioidosis is going to go up. Right, okay. Is there any question from the panel regarding melioidosis? No? Okay, so we'll carry on with the next speaker. Okay, the next speaker. Oh, sorry. Right. So our next speaker, our guest speaker is actually from Philippines, is Dr. Nilo T. Panar. Okay, so he's a associate clinical associate professor working at the Musculoskeletal Infection Unit at the University of the Philippines General Hospital. He graduated from the University of Santo Tomas, Faculty of Medicine and Surgery in Manila. He underwent his fellowship training at St. Vincent's Clinic, Sydney, Australia, and at Bone Infection Unit, Oxford, United Kingdom. He has an interest in hip and knee arthroplasty, as well as bone and joint infections. Dr. Panar is also actively doing research in orthopedic infections. I will hand over the microphone to Dr. Panar to enlighten us on fracture-related infection. Please, Doctor.
Thank you. Okay, I'll share my screen. Okay. Okay, good evening, everyone. And I'll be talking about fracture-related infections. So this is the Philippine General Hospital in Manila. And we are known to cater to the least fortunate of Filipinos. That's why we have been dubbed as PGH, people giving hope. I have no disclosures. Let me start with this phrase, primum non nocere. This is Latin for first do no harm. This has been the guiding principle for all physicians and surgeons for centuries. But despite our best efforts, we still encounter these types of complications after fracture fixation. Martin Algower, one of the founders of AO, mentioned in 1975 that the risk of infection remains the crucial issue of internal fixation. And today, more than 40 years later, this is still very valid. The real problem is actually biofilm formation. And we know that antibiotics are not effective against biofilm because of the following causes. There seems to be also a problem with the mere definition of an infection, especially after fracture fixation. Okay, let's look at this. During medical school, we were taught the 5 cardinal signs of infection, and they are the following. No? But what if we're faced with a case like this, wherein we can't really see much of the 5 cardinal signs of infection? So you may argue that this is not infected, but what we can see is the positive mirror sign. It's called the mirror sign because you can see a reflection on the surface of the implant. Okay. So another problem is multiple nomenclatures. Okay, they've described the complication in many names, and it tends to cause a confusion. And it's very difficult to do a very good literature review for your research when you're dealing with multiple terms. So with that problem in mind, in 2016, a group of international experts came together to come up with the consensus definition for fracture-related infections. Their purpose is not just to come up with a unified name, but also to have a standardized management for fracture-related infections. They came up with a confirmatory and suggestive criteria to define fracture-related infections. And when you talk about management of fracture-related infections, the first step would really be to establish the diagnosis. You must be able to identify your causative organism. Otherwise, you won't be. It's very difficult to treat something that you don't know what you're dealing with. Okay, so next would be to assess stability of your fixation. If the implant is not doing its job anymore, then you'll have to replace it or remove it. Debridement and antibiotics, they always go hand in hand for your treatment. Not one can stand alone. And your adjuncts to the management would be negative pressure wound therapy and local antibiotics. And of course, your end point would always be fracture healing or reconstruction of bone and soft tissue to return to function of your patient. Let's talk about biopsy and tissue culture. This is very important since I've mentioned earlier that you have to know what you're dealing with to be able to treat it. Okay? So this is always the first step of surgery. Okay? Before you contaminate your field with your debridement, you must be able to already take your tissue samples. You should apply the no-touch technique. Your gloved hand should not touch your tissue samples, otherwise they might get contaminated. You should take at least 3 samples, so multiple samples. And then you should use separate instruments whenever taking each sample so that there's no cross-contamination within your samples. Place them in sterile containers, no additives, and of course, label your containers. Some reminders though, before doing your tissue biopsy or taking your tissue cultures, there should be no antibiotics started. Otherwise, you might not be able to culture anything. And if the antibiotics has been started, then you'll have to put the patient on an antibiotic holiday for at least 2 weeks. This will increase your chances of actually isolating an organism. For samples, do not send like a component to the lab for culture or take swabs of the implant. Remember, biofilm, okay? They have mechanisms to elude diagnosis. It renders biofilm invisible to the host immune system. Sonication is used for diagnosis of biofilm infections. We do not have a sonication bath machine in the Philippines, so we have an ongoing study now using a portable ultrasonic cleaner. This is used for cleaning jewelry. And so far, our initial results seem to be promising. For debridement, you should always have that no fear attitude when doing your debridement for these cases. Sometimes you even have to do your oncologic debridement, wherein you have to do wide excisions to make sure that you have source control and you do a proper debridement. You should excise all sinuses, fistulas, and excise plaster scar or non-mobile skin. And of course, remove your metal implant if it's unstable or exchange it. For the antibiotics, it should only be started once your cultures have already been obtained, okay? And it should always be culture guided. You don't want the atomic bomb effect, you want the sniper approach whenever you give your antibiotics. And they should always be with the recommendation of our infectious disease specialists. For local antibiotics, they deliver high local tissue concentrations over the area of infection. And it avoids the potential for toxicity of systemic application since there's no systemic distribution of your antibiotics. It also doubles as a dead space filler. And the common antibiotics used are vancomycin, torbamycin, and gentamicin. The local antibiotic carriers, the most common would be polymethyl methacrylate beads or PMM beads or bone cement beads. And you have your calcium sulfate beads and bone graft substitutes. In the Philippines, we only have the PMMA beads, and we have to mold this intraoperatively. This is an example of an antibiotic bead mold, but unfortunately, this is not available anymore commercially. So I use now a silicone mold. This is actually a fondant cake decoration mold. Well, it serves its purpose, and it's reusable and easily easily sterilized with a regular autoclave. These are the fracture-related infection treatment strategies. Okay, so first, if the fracture is already healed, then no problem. You can just do a debridement, then removal of the implant and treatment of your osteomyelitis. But if the fracture is not yet healed, but you got the infection early, then you can do debridement with retention of your implant and then eradication. This is very similar to the DARE technique for PGIs. Then if your fracture is not yet healed, and you got it late, or your implant is not anymore doing its job, it's already unstable, and you got the infection late, then you'll have to do either a one-stage exchange or two-stage exchange, depending if the organism is difficult to treat. The last strategy would be a debridement and suppression until removal if, for whatever reason, you won't be able to remove your implant. And you'll have to do suppression until there's healing. But you usually will get into trouble with resistant strains here. Okay, let me share now some fracture-related infection cases that we treated during this pandemic in our institution. Case number 1 is a 46-year-old female who we saw 9 months post-op, underwent open reduction internal fixation of plate and screws for a close comminuted distal tibial fracture of the right leg. She presented with a sinus over the medial aspect of the ankle, and you could see the implant through that sinus, okay, with minimal exudates. These are the x-rays of the patient. There seems to be no loosening, no wiper sign, and the fracture seems to be healed. So we just removed the implant and did debridement, and these are the x-rays after removal of the implant. The fracture is already healed. Cultures turned out to be negative, but we sent the patient home on 4 weeks of oral antibiotics for treatment of probable osteomyelitis, as recommended by our infectious disease colleagues. Okay. For case number 2, we have a 27-year-old male sustained an open type 3B fracture of the middle third of the tibia and underwent multiple debridements, application of external fixator, eventual conversion to intermedullary nailing, And unfortunately, at 2 weeks post-op, there was wound breakdown. And during this time, there was already lockdowns in Manila. So we were only able to do follow-up with the patient via telemedicine. And due to stricter lockdowns, we were only able to admit the patient at 5 weeks post-operatively. So these were the clinical pictures of the wound breakdown at 2 weeks post-op. And this was the clinical picture at 5 weeks post-operatively. Okay. These were the x-rays of the patient, and you can see there are no loosening signs over the implant, and the fracture is still not healed. Though we needed to take out this implant since it's an intramedullary device. You cannot retain implants that are intramedullary because you won't be able to do proper debridement of the IM canal with an implant in place. Okay. So that's what we did. We opened up the fracture site and noted that the fracture edges were already dead. So we had to excise that around 6 centimeters of dead bone, and we were left with a large bone defect and soft tissue defect after our debridement and removal of the IM nail, which we could not, the soft tissue defect we could not close primarily. We placed in our Ilizarov rings. You might note that we had to do, the intermediate rings were not complete because we had to have provisions for our flap coverage. So we placed negative pressure wound therapy in the interim. This was the x-rays after the first surgery. And then culture growths revealed Pseudomonas. It was consistent through all our specimens, including the sonicate fluid cultures. This was the clinical picture after the second debridement, and the cultures now were negative, so we were able to schedule for flap coverage. We used the medial belly of the soleus, swung it anteriorly to cover for the anterior defect, and eventually had skin grafting. Then after that, we were able now to complete the Ilizarov construct and did double corticotomy proximally, okay, for bone transport. These were the clinical pictures upon graft site inspection. There's good take. Case number 3 is a 31-year-old male who 3 years ago sustained an open fracture and was treated at another institution, multiple debridements, application of external fixator, eventual conversion to an antibiotic-coated IM nail. Musculoskeletal technique was done for bone defect and eventually converted to an intermedullary with bone grafting. Fortunately, came to us 3 years later with 1 year history of multiple draining sinuses, and you could see the exposed head of the screw distally. This was the x-rays of the patient wherein there's a loose screw, distal locking screw is loose, and this was the area where the musculoskeletal technique was done. We were not really sure about the viability of the bone here over this area. So intraoperatively, though, we noted that there was good bleeding over that area. It was still viable. So we did not excise the area where they did the musculoskeletal technique. We just removed the intermedullary nail and then applied our Ilizarov external ring fixators and placed local antibiotics over the area. Culture showed multi-organism. It was Staph aureus and Enterococcus faecalis. And these were the x-rays 2 weeks after removal of our antibiotic beads. Okay, for our takeaway, early diagnosis of fracture-related infections and identification of the pathogen is really crucial. Proper surgical debridement and antibiotics is a must. And with the first sign of infection, please do not have that knee-jerk reflex of starting antibiotics. And if antibiotics have been started, always do an antibiotic holiday to ensure that you'll be able to culture your organism. And of course, for these very difficult cases, you always have to do the multidisciplinary approach. I'm very fortunate that I work in a hospital wherein I have all the specialties that can help to manage these types of cases. With that, I'd like to acknowledge my colleagues, Dr. Rachel Balcer from the Ilizarov Service, Dr. Tammy Montales from our microsurgery unit, and of course our colleagues from the Infectious Disease Service of UPPGH Department of Internal Medicine. I'd also like to thank our orthopedic residents, Rafi Cruz, Anya Peña, and Julius Abisamis for helping me put together the cases for our presentation. Thank you all for listening, and we are celebrating our 50th year of our department this year. Salamat po.
Thank you very much, Dr. Nilo Panar. I think it was just an amazing talk, actually. I quite like the a lot of things I learned today, tonight, actually. especially the mirror sign. Actually, I think that is something that I picked up from there. And I also enjoyed the, I learned something that we can make cement beads from the fondant cake template. Amazing. I think
It's very cheap, easily purchased online.
Exactly. I think I will introduce it to the department sooner. Anyhow, I mean, you did mention a couple of techniques for fracture-related infections management, namely the bone transport as well as masculate technique. I mean, with your experience, what's your take on these two? Which one would you prefer if you have a choice?
Okay. For smaller defects that's below 5 centimeters, you can do your musculate technique. So basically, you have to put in, on the bone defect, you have to put in a bone cement spacer and leave it there for 6 weeks. And then after that, you'll see that when you come back for it after 6 weeks, there'll be a pseudo membrane formed around that bone cement, and you can just slice it open and remove your bone cement and then place in your bone grafts. Okay. So, but that will only work for defects less than 5 centimeters. For larger defects, like more than 5 centimeters, it would be more appropriate to do your bone transport with the Elizarov fixator. Honestly, in our institution, we always do the Elizarov fixator since we have a very active Elizarov service in our hospital, in our department.
Okay. So for the muscular technique, as you said, you slice it open and then you put bone graft in it.
Yep.
Correct. Okay. So I'm just a bit worried that with putting another new bone graft in it, and the bone graft will get infected. This is another, I don't know, unless it's an autograft. Are you putting in another, synthetic bone graft with that, or?
Yeah. Usually they use autografts, so they probably will harvest in the ion canal of the femur using the RIA, it's a reamer irrigator aspirator. Tool, or they could put in some, scaffolding, with your bone graft. So that's a problem with your musculate technique because it really demands a lot of bone graft to be placed.
All right. Okay. Excellent. All right. Okay. I think we'll carry on with the next speaker. Let me just share my slide again. Right. Our next speaker here is from Thailand, Dr. Chittawee Jiamton from Bangkok. He is a graduated from Chulalongkorn University, Bangkok, Thailand. He had undergone his residency in Lertsin Hospital and fellowship of orthopedic trauma session with the Royal College of Orthopedic Surgeons of Thailand. Dr. Chittawee Jiamton also did a number of fellowships in Europe. He was awarded AO Fellowship in Trauma Surgery at Tübingen, Germany in 2015. He was working as a trauma fellow at Luzerner Kantonsspital Luzern, Switzerland in 2016, and as a trauma fellow at the University Medicine Johansen Gutenberg, University Mainz, Germany. He brings all the knowledge wealth and expertise home, and now he's working as an orthopedic trauma consultant, trauma unit Lertsin General Hospital in Bangkok, Thailand. Now I'd like to invite Dr. Chittawee Jiamton to the virtual stage to give us a lecture on the principles of management of open fractures. Please, Doctor.
Okay, let me share my screen. Can you see my screen?
Yeah.
Yeah.
Okay.
Yes.
Thank you for your kind introduction, and thank you for the AOA for invitation to this webinar. Most of the lecture is about infection, and my talk will cover the principle of management of open fractures. The importance of the open fracture is there is the list of infection, and the best method to treat infection is prevention. My talk will cover about how to manage the open fracture properly and to reduce the risk of infections. Open fractures are not only the fracture with open wound, it is rather the soft tissue injury complicated with the broken bone. And my talk will cover about the principle of management in open fractures, explain the adequate wound care in open fractures, and discuss the adjunct to prevent the infection. As you know, open fracture is associated soft tissue injury that create communication of the fracture site with the environment. And the list of complications is increased compared to the closed fractures, such as the infection and non-union. It requires a principle-based approach to decrease the morbidities and improve the prognosis. The fracture itself can present with variety of patterns, from simple to complex fractures, as well as the associated soft tissue injuries. It can present with only small open wound to larger, more contamination, and more soft tissue injury open wound. Our goal is the same as all fractures, but we need to manage the associated soft tissue injuries. We will try to minimize the risk of infection, allow the fracture to heal, and restore function of the injured limb. These are the principles of management in open fractures. First, we need to careful assessment and resuscitation following the ATLS guideline. Early systemic antibiotic administration, systematic debridement, wound management, and stabilization of the fractures. Open fracture may be associated with the serious life-threatening associated injury. Therefore, it is critical to perform a careful assessment and give appropriate resuscitation first. Then we evaluate the injured extremity, including a careful neurovascular examination, assess the size, location, and contamination of the open wound. The wound is irrigated with normal saline at the emergency department. Try to remove gross contamination and make the saline dressing. The fracture should be realigned and immobilized with the splint to avoid further soft tissue injuries. Start IV antibiotics and tetanus prophylaxis depends on the status of the patients, and prepare for the surgical debridement. Classification system aim to describe the injury, guide the treatment, and determine the prognosis. The common classification we are all familiar with is Gassilo and Anderson. It composed of type 1, 2, 3, and type 3 was subdivided into 3A, B, and C. And we know that the factors used in staging are size of the wound, fracture contamination, but more important are the severity of soft tissue injury and degree of contamination. The risk of infection depends on the severity of the injury. The more severe injury, more risk of infection. And most of the open wounds are contaminated with microorganisms. Therefore, antibiotics are not used for prophylaxis, but for the treatment of contamination. As we know, most common organism is gram-positive. Recommendation is the first generation cephalosporin for all types of open fractures. We add aminoglycosides such as the gentamicin for type 3. And if the injury occurs in the farmyard, add high-dose penicillin to cover the anaerobe. For the antibiotic, it should start as soon as possible at emergency room. The recommendation for duration for type 1 and 2 is 24 hours after surgical debridement and wound closure. If type 3, it can extend longer to 72 hours or maybe 1 or 3 days after the soft tissue coverage. It might be prolonged in antibiotic therapies if there is an infection on top in our open fractures. As well as the FRI, local antibiotics with antibiotic cement can be used in addition to systemic antibiotics. Following the insertion of antibiotic beads in the open fractures, the wound should be sealed so that the elute antibiotic remains at the injury zone. It allows high concentration in the injury site and can be used as the death management in the case of bone defect. There are studies support the lower infection rate when local antibiotics applied than standard systemic antibiotic alone. I can say the best antibiotic to prevent infection is debridemycin. Meticulously surgical debridement is critical. It is removal of all non-viable tissue, which is the source of infection from skin to bone. And the debridement should be performed in the operating theaters. It should be performed in a systematic and a traumatic way. From skin and subcutaneous are sharply debrided back to the healthy skin edge. Extend the wound with respect to the vascularities of the soft tissue, as well as the definitive fixation. You need to plan for your definitive fixation and also some possibility for flap coverage. Muscle is sharply debrided until only the healthy muscle is present. Usually we use 4 C's. Viable muscle usually characterized by the good color, contactility when touching with the cautery or forceps, good consistency, and good capacity to bleed. For the bone, cleaning the bone end with the curate, which protrude to the open wound. Bone fragment should be retained. If there is soft tissue attachment, that means there is the blood supply to that fragment. Floating, contaminating cortical bone can be removed, but the fragment which involved in a large articular surface should be retained for later articular reconstruction. The issue about the irrigations. Irrigation is the mechanically remove small foreign body and aim to reduce the bacterial contamination after debridement. It is the solution of the pollution. The recommendation is use only normal saline. Antiseptic solution can be toxic to the host cell and are not recommended. And recommendation, we use the gravity pressure or just low pressure because high pressure lavage has been associated with bacterial seeding into the deeper plane. The general recommendation for the volume, we use 3 lit for type 1, 6 for type 2, and maybe more 9 lit for type 3 open fractures. There are also controversy about the timing for debridement. Urgent debridement within 6 hours from injury has been considered important as unloading the microorganism contamination. But recently, the literature demonstrates insignificantly different in infection rate, whether early or delayed debridement. Small delay in surgery do not increase the infection rate and may allow for resuscitation of patient status, especially in the high energy injuries. It should be as soon as safe as possible, usually within 24 hours. For the wound management, I think we can follow the step ladder of soft tissue reconstruction ladder patterns, starting from the simple primary closure to more complex free flap coverage. It depends on your team and the expertise of the surgeons. In the present with soft tissue defect, as in type 3B, early soft tissue coverage is recommended. The choice of soft tissue coverage depends on the location, depends on the size of the defect, and overall soft tissue injury in that extremities. Fix and flap, which refer to soft tissue coverage at the same time as definitive fixation, has increasing in popularity now. This is limiting the complication associated with delay coverage. But anyway, this is not always possible in complex injuries, as well as the negative pressure wound therapy allow for delay flap coverage and keep the wound in the sterile situation until the definitive flap coverage was done. This is algorithm we use for the wound management in open fractures. Following the algorithm, you can see in less severe injury like type 1 or 2, is that if there is no list of infection, such as there is no soft tissue injury, not much contamination, the patient get early antibiotics and get early debridement. The wound was closed without tension. You can do primary wound closure. But in type 3A or 1 or 2, if there is any list of infection, you can delay the wound closure, consider antibiotic beach pulse or negative wound pressure. 3B, usually we cannot cross the wound primarily. So we left the wound open with the negative wound pressure or antibiotic pulse, and then consider re-debridement within 2 days. If the wound is able to cross at the second debridement, you can repeat debridement and closure the wound. If it cannot cross at that time, consider repeat debridement and consult for the early flap coverage. This is one of the example, open fracture proximal tibia with open wound. It was diagnosed as the Gastilo type 2 at least. Systematic debridement was done, and negative wound pressure dressing with the dermatotraction was applied with the external fixator. Then consider re-debridement with the definitive plate fixation, and the wound was closed primary suture without tension at the second surgeries. Another example is the open wound with distal tibia fractures, Gastilo 3B. The surgeon debride and planned for pseudoflap coverage. You can see the wound was debrided appropriate for later pseudoflap reconstruction. Then re-debridement, fix the bone and simultaneously flap coverage at the same setting. And the wound was healed nicely. For the skeletal stabilization, stable fixation reduce the further soft tissue injuries and facilitate wound care and allow early motion. External fixator is the mainstay in open fractures as damage control, as well as stabilization in type 3B or 3C fractures. And the choice of definitive fixation depends on the fracture location, depends on the soft tissue injuries, patient characteristic, and also the surgeon expertise. Most common step is if the fracture is type 1, 2, or 3A, you can do debridement. And then if you can definite treatment at the first debridement, you can do. If not, consider second debridement and do the definitive treatment. The most complex one is the type 3B. Usually we do debridement with external fixator, consider re-debridement and plan for soft tissue reconstruction, fix and flap, or you can reconstruct the soft tissue first and conversion to internal fixation later, and then manage the bone defects. I will demonstrate some cases before finish. This is 23 years old male, motorcycle accident, isolated injury. You can see the open wound, not much contamination. It needs to be confirmed in the surgical debridement. There is minimal comminution at the proximal tibial fractures, diagnosed as a Gastilo 3A. We did debridement, try to cross skin loosely, and we plan for second look debridement. At the first debridement, we stabilize with the standing external fixator. We repeat debridement at the time of definitive fixation. We can perform wound closure at the time of second debridement and consider minimal invasive plating for the fracture fixation. Another case is the multiple injuries, open fracture tibia with suspected bone loss. The wound was primarily debrided and crossed temporary fixation with external fixation before transfer to our hospital. When he alive, we consider re-debridement at the open wound of the tibia because it looks severe soft tissue injury. At the same time, in the second setting, we convert the plate fixation for femur for more easier for nursing care. Then, after multiple debridement, the wound looks good. We perform the local flap coverage with the antibiotic cement spacer to manage the bone defects. After the bone, the flap heal, we perform skin graft, and because of the last segment of bone defect, we plan for bone transportation with the monolateral external fixator. The bone was transport, bone graft at docking site when the transportation segment alive, the docking, and the bone heal, the flap heal. This is the stepwise management, usually in 3B fractures. The last example is the 52 years old female motorcycle accident. Open fracture distal femur type 3A and maybe 3B on the distal tibia. Initial debridement again with spanning external fixator. And you need to plan for multiple debridement to observe the wound, to observe the skin necrosis. Try to re-debride the muscle, which may not obviously necrosis at the first debridement. Remove all small bone fragments, remove all non-viable skin and muscles. It will result in soft tissue defect and bone defect. You can also perform fix and fab at the same time if the wound condition is good. This case was done free flap coverage with the free vascular fibular graft for bone and soft tissue defect. This is the radiograph after the surgery, and the bones, the flap was healed well, and our free vascular fibular graft was also healed very well. So, take home message. I think open fractures are challenging problems which are associated with the risk of infection, non-union, and sometimes amputation. The best way to prevent infection, to treat infection is prevention. It should be treated as urgency. Meticulously debridement is mandatory. Consider antibiotics as soon as possible. Consider early flap coverage and appropriate fracture stabilization. So thank you for your attention.
Excellent talk. Very superb talk by Dr. Chittawee Jiamton. I really enjoyed the talk, absolutely, because I think this is probably, you know, the bread and butter for almost every orthopedic surgeons in training, also who's been practicing as well. So I think what really interests me actually, one of the things that I saw in your slide was the negative wound pressure management. I quite see, I mean, when you show me that there is a tibia open wound and you're putting a dermatotraction across with a suction drain, how do you make that?
Yeah, it's just the saline. It's like you can use the fitting tube. Usually, it's the fitting tube. We don't use the commercial negative wound pressure. You can use the sponge medical grade with the fitting tube, and in that case, that is that surgeon use the Taroko, the chest drain tube for maybe just only the larger for the suctions.
I see.
Yeah,
okay.
but usually the commercial one is a bit expensive, so we use the manual one.
I agree. I think we've been in Brunei, we're using so much of this commercial one, and it's actually costing a lot of money for the country also. So I think I want to see an alternative to this, and I'm seeing a lot from this sharing of an ASEAN management of open fractures and infections. Secondly, actually, Dean, when do you consider you know, amputation then for a very bad open fractures?
Yeah, amputation is also an option in the case of very severe or mango extremity injuries. But before, I never perform primary amputation, just only in case of there is the life-saving surgery. If possible, we will keep the limb first. At that time, we can discuss with the patients about the choice of treatment. Yeah. So it depends on many factors for the bone defect or serious extremity injuries. It takes time. Sometimes it's more than a year. So we need to discuss the advantage and disadvantage, the time or duration of reconstruction with the patients. Yeah, usually I try to keep it.
Okay. Thank you very much for your experience and talk, Dr. Chittawee Jiamton. Okay. Thank you. I'd like to share my screen again. And I think time flies really when we are enjoying having fun here. And last but not least, I think we're coming to the last talk for tonight. So the last speaker is actually my colleague, Mr. Muhammad Abdul Hafidz. bin Haji Yakob. He's been working as an associate specialist in Ripas Hospital since 2020. He has completed his higher surgical training in trauma and orthopedics in Liverpool, along with me. In the UK, he has exited his FRCS exam and also recently graduated from the University of Liverpool with MPhil in orthopedic biology. Since his return to Brunei, he has shown keen interest in teaching and training, of which he is appointed as an orthopedic representative and member of Brunei National Trauma Committee, and as an assistant teaching program director for basic surgical training and junior clinical supervisor for medical student at the Institute of Health, University Brunei Darussalam. Mr. Hafidz will be talking about our current pandemic, which is being affecting everybody here, COVID-19 and musculoskeletal problems. Over to you, Mr. Hafidz.
Okay, thank you very much, Mr. Khairul, for the kind introduction. We'll begin my talk now. Okay, so my talk is something quite relevant at the moment, which is the COVID-19 and also the musculoskeletal problems that are associated with it. As you're aware, we're now coming to our second year of this infection, this pandemic, and I'll just start with the outline of my talk. So I'll be talking about the global impact of COVID, also the impact in orthopedic practice, and some effects on the musculoskeletal problem, and as already mentioned, some of the topics of interest to me. So beginning with the global impact, just going over a little brief history about COVID itself. So this sort of disease started at the end of 2019, when a mysterious cluster of patients in the Wuhan province started suffering from a pneumonia of unknown cause. So when they actually investigated, isolated this new virus called which they labeled as the SARS-CoV-2. So they tried to contain it, but unfortunately, by the beginning of the following year, started to spread over the borders, and the first documented case outside of China was in Thailand. And then by the end of January, the World Health Organization declared it as a public health emergency of international concern, and gave it the title of the disease COVID-19 in February, and then by March of 2020, we declared it as a pandemic, and then the whole world started to descend into chaos. So to date, we have now, COVID has now infected 256 million people around the world and has caused 5.3 million deaths. So how has COVID affected us in terms of the practice of orthopedics? So around about the time when the pandemic was happening, a lot of research and articles were being published, which was quite good. It helped add the information, and I'll try to summarize some of these. So what were the adjustments that were made? The adjustments were made across the board from the national level, with countries going into lockdown or stay at home, and also public health sectors trying to manage and modify their practices and diverting resources to where it was appropriate. And also in the beginning, it was a terrible time when even PPE and masks were all short, and there was a global shortage of things like this. So we were in a terrible crisis. But in terms of the local level of management, even then we had to reduce our services, downscale clinics, and some of our staff were also redeployed, and our shifts had to be adjusted. So I'm sure everyone is familiar with these type of implementations in their own hospitals, where, like it was mentioned, that the new hospital was changed to a isolation center for the level category 4 and 5 patients, I talked earlier just now. So these things have happened, and they are still happening in certain parts of the world as well. So in terms of orthopedics, how has our presentation of cases changed? In terms of the cases, you et al. Had performed a study in New York where they looked at 2 major hospitals that admitted trauma patients and looked at 35 of the main orthopedic type diagnosis. And you can see that all over the different categories, they there was a significant reduction in the number of presentations, and even in the most urgent cases of the major fractures, the ones only there were 4 out of 6 that were significantly reduced. So in terms of our operations as well, we had a reduction in the number of surgeries that we were doing. And this is also apparent on all over the world, where you can see even from Chile to Malaysia to Hong Kong, the general consensus was that the number of orthopedic surgeries was reduced, and there was a proportionally higher reduction in the elective cases, in particular the arthroplasties and also like ligament reconstructions. So what about the trauma that was left? What were we seeing? Most of the trauma that was seen was essentially things that the end of the spectrum, where things were happening. Patients were falling at home, with elderly patients sustaining femur fractures and humeral fractures. All the low energy injuries, where maybe because of them living at home unattended, they tended to fall, they were not looked at. And also with children, there was a reduction in the number of falls they were having outdoors. And this was generally what we're seeing overall. So in terms of the trauma that was done, you can see that there was a systematic review that was done by Kumar Jain, published in the Journal of Clinical Orthopedics and Trauma. We looked at 6 studies, and they pulled together the results and found that there were 44 patients who were COVID positive during those period of study that were actually operated on. And you can see that out of the ones that were treated, there was a 36% mortality rate. Now, bear in mind, this was during the time before vaccines were actually out. So now it might actually be a bit better, but still that's quite a significant high number of mortalities. And as you can see here, the majority of trauma that happened were essentially the hip fractures. So with hip fractures, what is evidence of how we're treating them during the COVID times? Excuse me. So Arafat et al. Also published in the journal, I think the Bone Joint Open, looked at a comparative study in the UK, and they studied the COVID as a cohort with positive and negative patients, and then a cohort from the previous year, looking at comparing the treatment of femur fractures. And you can see that there was a proportional increase in the number of fractures that were treated. But interestingly as well, there was a 36% mortality rate compared in the positive group compared to the negative group. And patients generally stayed longer in theater and also in hospitals. So femur fractures do remain a challenge. So in summary, in terms of how orthopedic practice was affected, the disease itself caused a significant strain to health systems all over the world, causing us to alter our practice and restructure our workforce. But also the lockdown procedures and movement restrictions also changed, interestingly, the presentation of trauma that we've seen. But osteoporosis still remains a challenge, nevertheless. So in terms of our experience in Brunei, as you can see, this is the number of doctors we have in our main hospital. You can see even during the normal times, we hardly have 20 doctors working, catering for the whole of Brunei. And then during COVID situation, 2 of the specialists were pulled away to various centers to look after, like an isolation center and the swab center. And across the board, the juniors have also been pulled to various responsibilities, including looking after vaccination centers and flu clinics. So we've been really running on a skeletal crew for some time. So yeah, and we've also had to cancel our elective cases, and we've only just been focusing barely on emergency surgeries, and ward closures and reduced clinics are also very much present at the moment as we are going through our second wave. So what are the implications for COVID and the musculoskeletal system? To be honest, there isn't much in terms of evidence, and it's still too early to tell in terms of any long-term results. But in the science behind it, the the SARS-CoV virus gains entry into the cells by the ACE2 receptor on the cell wall. This receptor is more primarily found in the respiratory system, in the lung tissues, and that's why you get the pneumonia. But it's also found in these other organ systems as well. So in terms of the musculoskeletal system, Abdullahi looked into it, and he assessed the neurological and musculoskeletal symptoms in patients suffering from COVID. And these were the most prevalent symptoms. As you can see, patients did complain a lot on myalgia and also back pain. But it's also worth mentioning that in terms of once they recovered, a lot of patients also suffered from muscle deconditioning, weakness, and fatigue. But this is more attributed to being in the intensive care units for long periods of time. So another interesting thing is that Disser et al. Did a more scientific study of this, and they looked at previously published data on gene expression on target tissues for the COVID virus, and primarily can affect the muscles and also bones and joints. And the effect of COVID virus, they attributed to direct viral effects, so cell damage, secondary effects from cytokine storm, where there's immune response upregulation, especially in interleukin-6, which can cause breakdown and bone density loss. And also in the early parts, intensive care units were relying on steroids to combat the effects of the virus, and that can also cause osteonecrosis and bone mineral density loss. Okay, so that is all I could find in terms of the effects of musculoskeletal, barring the old pain and back pain and muscle ache. So now an impact on training. So there have been some studies or some surveys that were done in Poland and also in the state in America that asked the trainees how they felt about working in the COVID environment. So the consensus is that there was generally a negative impact on the quality of training and the teaching, despite trying to convert to things like this, where you have online teaching, seminars. They still felt that they were not getting enough, and at the same time they were missing out on developing their motor skills. And there was also quite apparent that there was a lot of that affected their mental well-being as well. So in terms of the mental health, Sanghera et al. Did a systematic review looking at 44 studies which sort of tried to detect if there was any form of mental health issues with staff or healthcare workers working in the COVID environment. And as you can see from the table here, it comes at no surprise that almost a third of the workforce is affected by some form of mental health issues because of working the long hours with reduced capacity and also being in close contact with COVID positive patients. So in Brunei, essentially what we've also done a study during our first wave, which looked at similar things like this, where we surveyed the whole population of our doctors and dentists. We had a 40% response rate, and we looked at the depression, anxiety, and stress score, and also the OBI, the Occupational Burnout Index. And it was quite eye-opening to see that almost a quarter of the workforce was suffering from some form of mental condition, and about 85% of the healthcare workers were also suffering from quite a significant level of burnout. Now, this is quite worrying for the health system when you only have at most about 800 doctors working for the whole country. So this is quite a big, about 600 doctors are already burnt out. So that is something that we need to try and address. So just to close off, where are we in terms of moving forward with COVID? So in terms of COVID-19, a lot of countries now are seeing reduction in numbers of infections, and we're trying to keep things under control. But therein lies the issue that there is this, so to speak, hidden surge waiting to happen, where we are now having a tremendous backlog of our elective cases, that still need to be done, and also trying to get back to full capacity in the clinics, and also looking at the budget and long-term supply of our PPE testing kits, our reagents, and also negotiation with vendors. And also we need to think about getting the population vaccinated. So there's a lot of things still to think about for policymakers. But there have been some guidelines that have been provided by Parvizi, which main sort of take-home messages would be that when we start going back to the new normal, we need to prioritize our cases on what needs to be done first, and then also make sure we have protocols in place to reduce transmission and how to deal with positive patients, and then also supply of PPEs, and make sure that the workplace adaptations are in place when things try to start again. Okay, so that is pretty much it. Okay, thank you very much.
Thank you, Mr. Hafidz, for an outstanding talk. And to close off our lecture on musculoskeletal infection for tonight, there is some question actually. Maybe yeah, there's. I mean, this is probably just an opinion from you, Mr. Hafidz. An attendee was asking about fixing an early or later for geriatric hip fracture for COVID stage 4. So probably those people who are very unwell, who's almost pre-intubation. What's your thought about fixing a hip fracture during that time?
So with this type of patient, it's not just the health status that is in play here. You also need to consider the risk and safety for the staff as well, because presumably patients is still COVID positive and still infective. So it have to be a multidisciplinary decision with also the anesthetic staff. Mortality rate is probably going to be quite high in those type of patients because chances are they have other comorbidities as well. But we know that the sooner we fix a fracture, the better the outcome would be for the patient. So in terms of getting it done, we probably have to make sure that we have a lot of everything in place already. So you've got the ICU support, you've got the anesthetists on board, and then you do the operation that will be the quickest possible and just to fix the fracture. And most likely you have to just get one of the more senior surgeons to do it. So it won't be a training case, absolutely. You just have to get it done as soon as possible when the patient is fittest as they can be, and hope for the best.
And there's an extension of that question was, what about in COVID stage 2 who are already vaccinated? I think that's probably a bit safe when they're already vaccinated.
Yeah, the symptoms are relatively light. The thing is, if you can wait, then it's better to wait once they are screened negative. But again, if it's a neck femur fracture that needs fixing, you need to balance the risks and benefits and operate. But the recommendation is to wait till they are negative in those cases before you operate.
Right. So just another question from the panelists. I'd like to ask Prof.
If there's still time, can I ask?
Yeah, okay, yeah, you can ask one question.
Yeah. Actually, since we are talking about infections in muscles and bones and joints, one particular aspect which we have probably not touched is how do we go about in patients who've had septic arthritis or tuberculous arthritis, and we want to do arthroplasty in them, and both whether like if somebody is having an active septic arthritis or active tuberculosis, how long do you go after which you will do an arthroplasty, or say you do 1 stage or you do 2 stage, and similarly where you have a patient who's had a tuberculosis or septic arthritis long time back. Now you want to do arthroplasty in him. Again, whether you want to do 1 stage or 2 stage, you do first the Bremo and then you do later on. What are the thoughts about? I think that Professor Pang or someone else can throw light on that, because we do come across the dilemma many a times after treating patients with septic arthritis or tuberculous arthritis.
Okay, maybe that be directed to Dr. Pang Hini, if you could answer the question.
Okay, thank you for the question. So may I just clarify that the question is on the treatment of PJI in COVID cases. Is that
No. See, there are many patients who have got septic arthritis or tuberculous arthritis, and we want to do arthroplasty in them. So what is the timing when you want to do it one stage, you want to do two stage? If somebody is having active tuberculosis, when do you want to do it? After how many months of treatment, or immediately, like that?
Right.
Yeah.
Okay, thank you. So, right. So the important thing is to make sure that you treated the septic arthritis properly and completely, right? So how do you define this? Is by regular blood tests and biopsy. Okay, so when you've completed the treatment, the therapy, antibiotic therapy, and your CRP, your inflammatory markers are down, your knee aspirate or your joint aspiration with the biopsy are negative for the pathogen, right? Then you may proceed with arthroplasty, right? And for tuberculosis joints, right, it's not as difficult, as troublesome as a pathogenic joint, because tuberculosis, they respond well to anti-TB treatments. The pathogenic joints are the more difficult parts, more difficult infection to eradicate, right? So to answer the question is, there's no timeline to to the arthroplasty process as long as the infection is cleared. So I've done, for example, arthroplasty in a septic knee 6 months after the septic arthritis. I've done it in a year's time after the septic arthritis. Yeah.
Can I ask that question?
Can I add to that? Sorry, can I add to that?
Yeah, there are papers which are saying that there are differences in people who've done septic arthritis arthroplasty after inactive period of less than 10 years, more than 10 years. And some of them have said, no, we have done after 3 months of treatment in tuberculosis, and we go ahead straight away. Because there are thoughts that if you delay too much, also you are creating problems in the functional status of the patients. So these are the thoughts of the people. So that's why I asked that question. Well, of course, the parameters are going to be followed, but you think that just follow the parameters, timing is not a criteria.
Okay, there's a question here actually from Sofian. He says about open fracture management. He said he had a patient with open fracture type 3A, 29-year-old, diabetes, good wound at day 3, and developed NF. Not sure what that is. The question is when we should do second look in patient with low immune. Can I do a second look in routine if that's a good condition? So it's probably a question for Dr. Chittawee, Jiamton. They were asking about when can you go for a second look with someone with a low immune system after an open fracture?
I think it depends on the condition of soft tissue at the first debridement. We know that the host factors like a DM is the risk factor for infection. If the wound is not quite bad, you may observe, but if the wound have some questionable quality of infection, I will do re-debridement and examine the muscle inside again.
I see. Okay. All right. Now, I think one last question, actually, just a general question for Prof. Passion. Prof. Passion.
Yeah.
We were just want to know about how is Philippines coping with COVID-19 recovery in terms of orthopedic?
During the past 2 months, there was a surge in our cases. But lately, in the past 2 weeks, cases are down now to less than 1,000 per day. Whereas before, it rose up to about 20,000 per day sometime in around September and October. No? So with the good semi-lockdown and good protocols for the prevention and the spread of the disease and more testing available in the Philippines, the cases are now almost getting very minimum already. So much so that in Metro Manila, before we were actually in a level 4 lockdown. Now it's down to almost level 2. So people are now allowed to be out in the mall, but of course in a less percentage, about 75%, of course. And then so the activity in the city and in the provinces are much more tolerable now. And hospitals are no longer that busy in getting these COVID cases. So the frontliners are more or less in a slow down mode now, and hopefully before December comes, December is a very festive month in the Philippines because of Christmas, and almost everybody's waiting for the further decrease in the number of COVID cases, so they can celebrate very well the Christmas season. So getting better.
Good. Okay. I hope it will continue to be getting better for everybody else.
Yes, hopefully. Yes.
Okay. I think so I'm gonna sign out very soon. I think before I sign out, I'd like to hand over the podium to Dr. Dr. Ketan Pande for closure. Thank you, Dr. Ketan Pande.
As president of the host society for the webinar, it's my duty and privilege to thank a number of people who have been instrumental in what I assess is a very successful webinar. In addition to the numbers I can see here, there's some information to suggest that we have close to 1,000 attendees, including those from live streaming. I must thank the office bearers of AOA for imposing their faith in us and guidance from Prof. Lee and Prof. Denny. I think Mr. Khairul has done a wonderful job as a moderator. And all this wouldn't have been possible without the expert faculty who have prepared their lectures very well and willingly shared their experiences and cases with all of us. We had a few panelists, colleagues who were monitoring and made sure that the webinar goes off well, and I'm thankful to Dr. Philip, Dr. Faik, and Dr. Sonali for this. Thanks also to colleagues from my Orthopedic Society who have attended and in some or the other way helped us with the webinar. Special mention about Indonesian Orthopaedic Association, who were the main guide and support behind, say, scheduling and conducting this webinar. And there was a lot to learn from them. OrthoTV is managed by Dr. Ashok Sham, who was always there to guide me, together with Dr. Neeraj Bijlani. And how can I forget the delegates who have taken their time out on a Saturday evening to attend the webinar. A brief announcement about the third AOA webinar, which will be hosted by Malaysian Orthopaedic Association. It's scheduled for the 22nd of January next year, so please block this date. And the subject would be hand and microsurgery. I would request the panelists to stay back for another photograph, and once again thanking all the delegates and wishing them good luck. Good night.
Congratulations to Brunei Association.
Thank you.
Congratulations, Prof. Ketan.
Thank you very much for your guidance. I think
thank you, Ketan.
As a small
really
team,
nice.
We have done very well. Thanks, Danny, for your kind words.
Thank you, Ketan. Very nice.
I think I'll get Sham. Could you come on the video, Dr. Ashok Sham? Maybe I'll request Sonali to take a picture with all of us smiling. Yeah.
Very successful evening.
Thank you very much, Prof.
Thank you very much.
Are you done? Great. Thank you very much. And we'll see you again in
everyone.
A couple of months.
Right.
Have a great
weekend.
weekend.
Good weekend.
Have a great
Thank
weekend.
you, everyone. Have a good weekend.
Good night.
Bye.
Bye. Good night.
Thank you.
Yep. Bye.
Host can stay. Host, maybe we can have picture of hosts also.
Wait, I want to leave first.
Our moderator is gone.
Red and Noble. Can I take picture? Has Khairul left?
Might have left.
Yeah.
No, Khairul is here.
Moderator,
Khairul.
need to stay back.
Yeah, I want to have a picture.
And before you take a picture, let me personally really thank all of you. And you can imagine your contribution, and it was a big learning step. And I'm glad we jumped onto this opportunity. And the result is for all of you to see.
Yes. My laptop
But
just,
Brunei,
I don't know what happened.
Yeah.
It's okay, but again, we managed that without much hiccup. It was good to have these 3 monitors around. Thanks, Mike, Philip, I think Hafidz. The talk was wonderful, a very comprehensive overview. And yeah, Khairul, you did well too.
I
Only
hope,
two, huh?
Yeah. I think maybe it's time to buy you a new laptop, is it?
I'm going to take a picture again, guys.
Yeah.
Please do.
Mr. Pande has not been appreciated by anyone. Huh? He's done a big job.
No, it's we know what we have done, and it's for our good, taking things forward.
Maybe you come forward a bit. You're a bit.
Oh, is it a bit?
Not. Yeah, I think come forward because I want your picture. Yeah.
You're
Okay,
looking
smile.
darker than me, Hafidz.
Yeah, the light.
Maybe the light, you don't
I'll
have
Photoshop, don't worry. Okay, smile, guys.
Okay.
Thank you.
Okay.
Wonderful. Ketan lost his earpod.
Doesn't matter. I don't think it makes a difference.
Lost means what? Somebody has
Lost means it's
stolen.
not working. He's saying, give me something. And I had only something in my travel kit. Who has traveled last 2 years? I had to hunt for the travel kit. But everything went off so well. So proud of Brunei team, huh? Reaching out to 1,000 people. Well done.
Yeah, thank you, Dr. Pande, for getting us in. And I think it's a good,
We'll continue to do that.
yeah, I think it's a good event. And I think
Good
despite
night. I think we kept you
Yeah.
away from your families.
Okay,
Engaging.
Okay, thank you, everybody.
Okay.
Okay.
Thank you.
Bye. Good
you.
night.
Bye.
Bye-bye.
everybody. Yeah. Well done.
Bye.
Okay.